feeling low. Only hate the road when you're missing home. Only know you love her when you let her go. And you let her go. Staring at the bottom of a glass, hoping one day you make a dream last. But dreams come slow and they go so fast. You see her when you close your eyes. Maybe one day you'll understand why everything you touch slowly dies. 'Cause you only need the light when it's burning low. Only need the sun when it starts to snow. Only know you love her when you let her go. Only know you've been high when you're feeling low. Only hate the road when you're missing home. Only know you love her when you let her go. Staring at the ceiling in the dark, same old empty feelings in your heart. 'Cause love comes slow and it goes so fast. Well, you see her when you fall asleep, never to touch and never to keep. 'Cause you love her so much and you dive too deep. Well, you only need the light when you're burning low. Only miss the sun when it starts to snow. Only know you love her when you let her go. Only know you've been high when you're feeling low. Only hate the road when you're missing home. Only know you love her when you let her go. And you let her go. Cause you only need the light when it's burning low. Only hate the road when you're missing home. Only know you love her when you let her go. Yeah, you only need the light when it's burning low. Only miss the sun when it starts to snow. Only know you love her when you let her go. And you let her go. You and me, we used to be together, every day together, always. I really feel I'm losing my best friend. I can't believe this could be the end. It looks as though you're letting go. And if it's real, well, I don't want to know. I'm standing on the corner in Winslow, Arizona. Such a fine sight to see. It's a girl, my lord, in a flatbed Ford, slowing down to take a look at me. Come on, baby, don't say maybe. I gotta know if your sweet love is gonna save me. We may lose and we may win, though we'll never be here again. So open up and climb in, so take it easy. When I'm riding down the road, try to losing my love, got a world of trouble on my mind. Looking for a lover who won't blow my cover. She is so hard to find. Take it easy, take it easy. Don't let the sound of your own wheels make you crazy. Come on, baby, don't say maybe. I gotta know if your sweet love is gonna save me.
Let's make it like a final ring. Okay. Uh, so, dear colleagues, dear friends, let's start our meeting today. We have a special day today. So we have a collaborated meeting of Israel Urological Association and European Association of Urology section of and Urotechnology. And today, all the meeting will be dedicated to BPH, benign prostatic hyperplasia. Leading experts from all over the world will share their experience. We'll discuss the hottest topics. But before we start, I would like to say a word of in the memory of Professor Ali Guzen, who was for a long time was the head of European Society of Urotechnology. And Professor Guzen was not just a person who was the head of a big team. He was an amazing researcher, was an amazing surgeon, amazing person, and the one who tried to unite urologists all over the world. So Professor Guzen is, in my memory and the memories of in the hearts of all urologists all over the world. So now let's start our meeting, dear friends, dear colleagues. So, and I would like to invite Professor Jack Beniel, the head of Rabin Medical Center, to say the word welcome. Professor Beniel, please welcome.
Thank you, Dmitry. Thank you, everyone here. This is really a special day for us. And it started actually, I think this is the first time in this hospital there's an international meeting. So this is a first in 80 years. The joint department is at Bellinson and Shaon and Schneider. And here, like 20 years ago, we moved all the endourology. And to tell you the truth, it was a real success. Just like 10 years ago, we would stand here and we would say the patient needs a TORP or SPP or RPP, and we would argue endlessly. Today, who knows these names? Today it's HOLEP or BIPOLEP or TULEP or all these new guys on the blocks, and that's what we're going to see and learn today. So I'm really excited, and I want to thank all the members and all the people that came and made this possible. We have also a lot of guests from overseas, and I want to greet them. So for the local staff, we have Yaron Shalit and Yaron Shilat, sorry, who are really innovative in making this possible. The local urology team, Yaron, 7 years ago, I think we started doing the HOLEPs. And last year we moved the 1,000 procedure. So I think this is a big accomplishment. And now we currently have 4 active surgeons doing HOLEPs here. I think this is really a big deal for Israel. Special thanks to our new star teacher, Dmitry Enikeev, please. Who is behind this great day and has brought us to the forefront of European experts in the field to our meeting. And I want to thank all our guests from overseas and from Israel who came from all over. This is very complicated times for Israel. We are at war in 7 frontiers for more than a year. So yet we can have this meeting without any interference due to our outstanding army. As we speak, some of our residents are currently serving with our forces in Lebanon. So we are very, very lucky. In the 80s, the name of this hospital was changed from Hasharon to Golda Meir. Golda Meir was a very famous prime minister in Israel. And in 73, in Yom Kippur War, there's a famous site when Joe Biden, he was a young senator, he came to visit Golda Meir. And she told him about the war and everything, and he tells her, look, I'm really depressed. But she said, look, you have to listen to this. We have in Israel a secret weapon, stronger than anything. What is this secret weapon? We have nowhere to go. So let's have a wonderful day. Thank you.
Thank you very much. And Professor Thomas Herman, the head of prostate group of section of endourology in European Association of Urology, Thomas, we are very pleased to see you. Thank you very much for finding time. Thank you very much for organizing this meeting. And please, the floor is yours.
Yeah, thank you very much, Dmitry, and thank you very much for actually you organized it. So I just was your sidekick. Let's be frank, yeah. And we are very pleased to be part of that meeting as EAU Endourology prostate group. You know that we have been just formed lately. It's just 2 months young now. This is a succeeding organization of ISUT. He just told it. I think it's very important to have these meetings, not only in this time, but also in the future, not virtually, but really. So we are very looking forward to that. I'm very proud that, as you said, that we have all the key players around that can tell us about their special technique and their insights. I think this will be a very fruitful meeting. And I also want to thank Nia Kleinman and Shankar Ahorni, who are also in the board of organization of this. So let's have a nice meeting. And I'll give the floor back to you.
Perfect. Thank you very much. So thank you very much, dear colleagues. So I would like to invite the panelists for the first session and Dr. Yaron Ehrlich with the first presentation with to highlight all the modern techniques. Yaron, please, the floor is yours. And the panelists, please take your seats.
So good morning. I was given the task to present a brief update on where we are now with minimal invasive therapy for BPH, and really to give an appetizer to the wonderful day we will have ahead. So let's give it a go. So the guidelines, both the European and the AUA, divide the treatment options into 3 groups according to prostate size, that is up to 30 cc, 30 to 80, and above 80. So it requires us as a urologist to measure the prostate size and also to look for a median lobe. And generally speaking, the AUA guidelines are more permissive, allowing more technologies to enter the flowchart, whereas the European guidelines are more strict on the evidence, leaving some devices out until we have more data. And I want to start actually with TURP. QRP remains a gold standard for almost 100 years. QRP is currently challenged by recently introduced treatments claiming advantage over TURP. And this is really a landmark study conducted in the 1980s in veteran hospitals across the US. So over 500 patients with moderate LUTS were randomized to TURP or watchful waiting, only watchful waiting, no medical treatment. And after 3 years, there was a significant improvement favoring TURP for the risk of urinary retention, improvement in IPSS, and improvement in flow rate. The study also showed nicely that TURP does not cause incontinence, and in selected patients may even improve continence compared to watchful waiting. It also demonstrated that TURP does not worsen sexual function compared to watchful waiting. And what happened next was that every new technology was compared to TURP as a gold standard. So this is a patient of mine who was referred for prostate surgery. He had severe LUTS while on tamsulosin and dutasteride. His prostate volume was 85 cc with a grade 3 median lobe protrusion. And I performed the TURP. This was before I started doing bullets. I removed about 30 grams of tissue, and I was quite happy with the result, and so did the patient. But
2 years later, he came back to me with hematuria and mildly elevated PSA. So I did the entire workup. I did a CT urography, which you can see here. I did a prostate MRI due to the elevated PSA, and I also performed a cystoscopy. And all it was, this is a very typical finding. Looking at the CT scan, you can see nicely that the QRP failures, we are able to nicely open the bladder neck, but I left a lot of tissue behind. So I also started him on the dutasteride. So although the patient is happy, like he says, 6, and he never had another episode of bleeding, it can be considered a QRP failure. So had I removed all the adenoma in the first surgery, this would not have happened. We would need the dutasteride, we would need all this workup, CT, MRI, and so forth. So I started doing HOLEP 7 years ago. I will not speak much about HOLEP because we have Enikeev coming right after me, tell you about the data. All I can say that this is how it should look after an enucleation treatment. So there should be an empty prostatic lozia. That will ensure a good outcome for the patient. So pros and cons for enucleation procedure, being HOLEP or robotic or whatever. I think it's a gold standard according to the guidelines, certainly for for prostate over 80 grams. It has a favorable reoperation rate of about 2% long term. This is better than any other procedure. It's extremely effective for urinary retention, even for chronic retention with success rates of almost 100%. So this is probably the preferred surgery. And the downside is transient incontinence, retrograde, almost universal retrograde ejaculation, and a steep learning curve. We are fortunate today to have some leading experts. So I'm very looking forward to hear Dr. Fernando Gomez Sanchez on his technique, on how he improved continence after HOLEP. I'm looking forward to hear Dr. Thomas Herman on how to preserve ejaculation in HOLEP surgery, and maybe ask him in this procedure, prostate ejaculation sparing HOLEP, is it really true anatomical enucleation or something else? And also looking forward to hear from Javier Romero Otero on robotic simple prostatectomy in the era of endoscopic enucleation. And I'm sure we'll have a hot debate with Dr. Dinesin here on what is best for the very large prostate, about 300 grams. So moving forward to aquablation. So this is only endorsed by the American guidelines, still not enough evidence for the European guidelines. So the aquablation, and you'll hear about it more from Dr. Shapiro, is a high velocity saline stream that ablates the prostate tissue under real-time transrectal ultrasound guidance. The guidelines rely on 2 studies, the WATER and the WATER-2 studies. The WATER study is a double-blind, multi-center randomized trial that compare 180 patients with prostate size of 30 to 80 grams that were randomized to QRP or aquablation. And the WATER-2 study is a single-arm, multi-center study that looked at prostate of over 80, actually 80 to 150 grams following aquablation. So pros and cons. So pros, this is the aquablation. It showed a similar 5-year improvement in Qmax, IPSS compared to QRP, and maybe even better for the aquablation in the 50 to 80 grams. So this may be the sweet spot of the aquablation. It had a fewer complication, adverse events, grade 1 and 2 compared to QRP. And this is probably the most important, amongst the sexually active men, rate of anejaculation was lower with aquablation compared to QRP, 10 versus 36%. The downside is the bleeding complications. But over the years, the surgery was modified, and the water and water two studies, in the studies was achieved with tamponade with catheter traction. But now most surgeons will take out the TUR loop and do some minimal TUR to bladder neck and some hemostasis. So I'm looking forward to hear from Dr. Shapiro and ask him if we can still quote the 10% ejaculation rate, even though we have changed the surgery. We now use no diathermy. We do more than a single pass of the water jet. So it will be very interesting to hear because we have little data on aquablation. This is why it did make it to the AUA, to the EU guidelines. Moving to the UroLift. Also, UroLift has mature data to enter both guidelines for the moderate size prostates. It is a permanent implant that pulls the lumen of the prostatic urethra towards the capsule. The guidelines are based on the LIFT study, which is a randomized compared trial comparing UroLift to sham operation in 200 patients, and also on the BPH6 study, which is a randomized trial comparing 80 patients between UroLift and TURP. So pros and cons. UroLift can be performed as an outpatient procedure. It improves the IPSS and quality of life over sham operation at 5 years. It has a shorter recovery time comparing to TURP, and 70% patients did not need the catheter, and no retrograde ejaculation. And the downside is that the IPSS, QMAX, and post-voided residual were better for TURPs than after UroLift. For patients with retention, successful removal of the catheter was only achieved in 90% after 1 month. So maybe this is not the best operation for patient in retention. And 5-year surgical retreatment rate was 14%, in addition to 11% who required medical retreatment. So about a quarter of the patient will need further treatment after UroLift. And we have very limited data regarding patients with median lobe, so currently it is not advised. Really looking forward to hear from Dr. Dean Elterman, who is an expert on the field on where we stand now with UroLift. Moving to Resume, again only in the American guidelines for medium-sized prostates. The Resume uses steam, which is delivered transurethrially into the transitional zone and causes ablation of the tissue. The data is based on the Resume study, which is a randomized control trial of the patient randomized to Resume or sham operation in ratio 2:1. Patients were discharged with a catheter for 3 days, and there was an improvement in the IPSS starting at 2 weeks and peaking at 2 to 6 months. Pros and cons: it can be performed as an outpatient procedure. It can treat a median lobe. It does improve IPSS and QMAX, and it does preserve ejaculation and erectile function. Downside: there are irritative symptoms lasting about 2 months, depending on the number of injections per lobe. So if you do only 1 injection per lobe, patient will recover quickly. The success rate of trial of removal of catheter in patients with retention is only about 90 to 70%. So again, maybe not the best operation for patient in retention. And retreatment rate was low, only 4% after 5 years, another 11% with medical. Really looking forward to hear from Kevin Zorn on the long-term outcome of this procedure, and he will lecture us later on this day. Moving to ITIN. This is an Israeli device bought by Olympus. Again, endorsed only by the AUA guidelines. Still not enough evidence for the European. This is for a medium and small-sized prostate. ITIN is a nitinol device that is deployed in the prostatic urethra is left in place for 5 days, so to compress the tissue and cause some ischemic necrosis. And it does result like as in causing a result like a TYP action. The data is based on a randomized study, randomized control study, 175 patients who were randomized 2-to-1 between IT and sham procedure, and also on a MT02 study, which is a prospective multi-center study on 81 patients. Pros and cons, it does improve IPSS compared to sham, but not a great difference. 78 to 60%, 3 months in the Q, and also the Qmax compared days improves compared to sham. It does preserve ejaculation and erectile function. With the downside that it does cause some irritative symptoms as long as the device is left in place, and it should be left in place for about a week. There's a 10% surgical retreatment rate after 2 years, and we have no data on patients with indwelling cancer. PAE, prostatic embolization, and nuclear of the blood. Although it does not appear in the guidelines, it does have a lot of data out there, and I'm not really sure why it's not there yet. The data, we have a meta-analysis of 11 randomized control studies comparing TURP and PAE. We have one randomized study comparing PAE to sham operation. For pros and cons, it is an outpatient procedure. It improves IPSS on Qmax compared to sham. It does preserve antegrade ejaculation. With the downside, it is a long procedure, does take skills, does have some radiation exposure, high retreatment rate, and when comparing to TURP performs better. Really looking forward to hear from Dr. Dominique Abet, who conducted a randomized controlled trial comparing PAE to TURP. So I'm looking forward to hear his, as a urologist, his perspective on who is the best patient for this procedure. 2 more slides. So we have transperineal laser ablation, TPLA. This has been around for a few years, not much data on it, so it is performed here in Israel. The data, so this is a laser ablation done transperineally like a prostate biopsy. And the laser ablates the tissue. The data is based on a single center randomized trial comparing TPLA to TURP, although there was some issue with randomization, so I would call it a quasi-randomized study. Prostate volumes were 25 to 90 grams, no median load. And pros and cons, this is an outpatient procedure. There is an improvement of IPSS and Qmax compared to baseline. There is a preservation of ejaculation. And the real advantage is that there's no instrumentation of the urethra apart from the catheter. The downside that it does requires long-term catheterization, so the patient is sent home with a catheter. And overall, TURP performs better. The last slide, a new kid on the block that I think will appear in the next guidelines. This is the Optilum balloons that we are used to here in Israel to treat urethral strictures. Here it is a different balloon, but the same coating with paclitaxel. The system uses 2 balloons, one balloon to anchor the treatment balloon in place, and a second balloon to inflate the prostatic urethra and breaks the anterior commissure. And then you inflate second time with a drug-coated balloon to deploy the chemotherapy agent to the fractured commissure, hoping that it will not heal back. So we have a landmark study. It's a clinical study by Steve Kaplan, but also co-authored by Dean Alterman, who is with us today. This is a double-blind, randomized, sham-controlled study. Phosphate volume were 20 to 80 grams without a large median low. And there was a significant improvement of IPSS from baseline, although most of the improvement was from the sham operation, but it is a significant improvement. This is the largest Qmax improvement we've seen in any minimal invasive treatment of BPH. It was almost 10 point improvement in Qmax, very low rate of anejaculation, and very low rate of surgical retreatment. So this is a promising device that we will hear about in the future. So thank you very much, and we'll continue with the presentation.
Thank you very much, Sharon. I think we'll moving on, and we'll discuss all the techniques in detail, and questions will leave for all the techniques. So moving on. Cool. Now we'll talk about endoscopic enucleation of the prostate. So, and maybe a new standard for BPH treatment. Let's discuss it. Let's think about it. So, but I think it's an important sign when Yaron presented at Water 1 and Water 2 trials for aquablation. Now we have Water 3 trials, and the goal of this trial is to compare aquablation with Holland. So we see that endoscopic ablation is becoming a new standard of treatment. So, and the question is every prostate is eligible for endoscopic ablation of the prostate? So we have a lot of debates during international meetings, and now I will try to answer to all these questions. So 1986, 40 years ago, the first endoscopic ablation was performed in Japan by Hiroka. What did he did at that time? He used an electroloop, performed endoscopic enucleation, but at that time, morcellata was not developed. So he performed endoscopic enucleation and leave tissue at 12 o'clock position, and then with a loop, resect all this tissue. He published this data, but as morcellata was not developed, the technique was not so popular in that moment. And not only in 1998, Peter Gilling from New Zealand used holmium yak laser from Luminis, Israel company, and the Luminis presented the first urological morcellator at that moment. And after that, endoscopic ablation, it became more and more widespread all over the world. So what is that it make endoscopic enucleation of the prostate be acceptable by urological community all over the world? It's minimally invasive, recovery is quick, long and short-term outcomes are satisfactory. So once again, if we look at the guidelines, we will see that both European and American guidelines accept endoscopic enucleation of the prostate as a size-independent option. The only one difference that European guidelines accept all energy sources, while American guidelines focuses only on laser techniques. Some time ago, we were invited by Cesare Scapone for debates in European Urology Open Science. So for which laser is the best for endoscopic ablation? So it was my privilege to be together with Fernando Gomez Sancho, with Thomas Herman. So we discussed which energy source is better, thulium yak, thulium fiber, holmium yak laser, which laser is the best for endoscopic ablation of the prostate? And I think the answer was given by Thomas Herman in 2016. So that enucleation is enucleation, no matter what kind of energy source you use. So Professor Herman quoted the famous poet Gertrude Stein, who said that rose is a rose and there is nothing to add. So enucleation is enucleation and there is nothing to add. So some time ago, we were involved in comparison more than techniques. So it was holmium yak laser with Moses effect and thulium fiber, big multi-center study. We compared and found that once again, all energy sources are comparable. hospital stays, stress urinary incontinence, no matter what kind of energy source you use. Functional outcomes, the same. But what is the difference? The difference is learning curve. And we conducted also a trial on this topic, and we found for thulium laser, thulium fiber laser, it's easier to learn endoscopic inflation of the process. We know that there is a stereotype that endoscopic inflation has rather steep learning curve. So new energy sources allow to minimize this learning curve. New thulium fiber laser, and today we will see this procedure. I hope we'll have this live surgery and we'll see all the advantages of this energy source. But this energy source allows it for quicker learning curve. This is the main advantage. So if we compare endoscopic inflation of the prostate with transuteral resection, so if we talk about short-term outcomes, of course they are comparable. All patients start urinating. But long-term outcomes, please read our meta-analysis in World Journal of Urology. Version of Turpey, it's meta-analysis, Turpey and endoscopic inflation of the prostate. All benefits, long-term outcomes, all benefits go to endoscopic inflation of the prostate. Long-term outcomes, better catheterization. After endoscopic inflation, 95% of cases, 1 day. Hospitalization, 1 day. Hospital stay, 1 day. So we know, for example, in Germany, due to its insurance system, they keep the catheter for 2 days, but it's only for the insurance system, and they need to do that. Complications, less after endoscopic inflation of prostate. Erectile function, better after endoscopic inflation of prostate, was proven also in our trials. Recurrence rate, of course, and it goes without saying that it's better to remove the adenoma completely than just to resect a part of it. So relapse after transuteral resection up to 10%, in some trials up to 15%. A lot. So now, for example, in National Clinic, there is no, we do only endoscopic inflation for all the process, no matter what size. Some time ago, we have a debate in Austria with a great expert and my friend Mario Sofer regarding small glands. What about extra small glands, less than 30? Would you do TURP or endoscopic inflation of the prostate for these glands? Dr. Gnessen, what about you? What do you prefer to do in such cases? Okay, so it's clear. So some studies were conducted, and I promised Mario to present these studies. So this study comes from Luftitung, from our Turkish friends. They compared data patient polyp for less than 30, more than 30, no difference in terms of functional outcomes. Some intraoperative complications, recateterization, were higher in small glands, less than 30, but it goes without saying that it should be done in experienced scans. BPH is not formed yet, and it's difficult to separate adenoma from the capsule. But in experienced scans, it's absolutely doable. In other studies come from Asia, from South Korea, and from Japan. Big number of patients, less than 30, more than 30, no difference in functional outcomes, no difference in complications. Conclusion, effective in all sides of the prostate. So if we compare endoscopic inflation, once again, we don't call it polyp because polyp is holmium laser inflation. Now we have many energy sources. We say endoscopic, anatomical endoscopic inflation of the prostate. If we compare it to TURP, 1 day catheterization instead of 2 or 3 days, shorter hospital stay, less hemoglobin loss, hemoglobin drop, efficacy, short term, comparable, but all benefits for long term go for HOLIP, more tissue removed, goes without saying. If we compare HOLIP for endoscopic inflation for glands less than 30, more than 30, of course, the operation time is shorter. Potential risk of intraoperative complications, catheterization, recatheterization is higher, of course, so then it goes without saying. What about huge glands, more than 80 cubic centimeters? Such studies, of course, were conducted. So if we talk about functional outcomes, the same. Catheterization, Of course, 1 day after endoscopic inflation of the prostate. Complication, better after endoscopic inflation of prostate. Erectile function, better after endoscopic inflation. Recurrence rates, also better after open simple prostatectomy. This is all the data from meta-analysis, not just from some studies. Nice study from Tevahau, also our friend. So he conducted a study comparison nucleation for glands less than 200 and more than 200. Stress urinary incontinence, functional outcomes was absolutely comparable. Another study comes from Mitchell Humphrey from United States. Also glands less than 300 cubic centimeters and more than 300. All the same. Data, all the same. Functional outcomes is all the same. What is the biggest gland which was operated on with endoscopic inflation of the prostate? So if we look at the data, we'll see 436. The largest one is 696. Some time ago, here in Asharon, Dr. Ehrlich did the procedure for 650 cubic centimeters. So we see that it's absolutely doable. And the patient next day went home and he was more than happy. So, but of course, now robotic approach is becoming more and more widespread. And we talk about robotic simple prostatectomy. What about comparison enucleation with robotic simple prostatectomy? Okay, so functional outcomes, the same. Operating time, well, better. It's better with endoscopic inflation. Catheterization, once again, better. Hospital stay, better. Complications, transfusion rate, less. Urinary incontinence, there is a stereotype, and we will talk about it during the presentation. So there is a stereotype that after HOLIP there is incontinence, high incontinence rate. It's not so. It's not so, and I hope that during our meeting today, we'll present all the data. It's not really so in experienced hands. Functional outcomes, same recurrence rates. If we do it with robotic approach, simple prostatectomy, we clearly see all the nodules, remove them. It's absolutely the same like with endoscopic inflation of the prostate. So if we compared, once again, if you compare the inflation with robotic simple prostatectomy, shorter operative time, shorter catheterization, less transfusion rate, efficacy comparable. If we compare enucleation for smaller and larger glands, okay, of course, for larger glands, operating time is longer, similar catheterization, a little bit higher hemoglobin loss, efficacy, safety, absolutely comparable. What about salvage enucleation? Can we do endoscopic enucleation of the prostate after TURP simple prostatectomy? Can we? Of course, we can. And we conducted that with our German colleagues. We conducted a study on this topic, and we found that absolutely no differences. Primary or salvage endoscopic inflation, all the outcomes are the same. No significant difference. Even now we have a meta-analysis systematic review on this topic. More energy sources required for salvage surgery. Of course, risk of urethral stricture is high as a repeat surgery, and we know that any repeat procedure on the urethra has a higher risk of urethral stricture afterwards. But no significant difference in all other aspects. Is it possible to do endoscopic inflation after urolift? And we see such patients sometimes. Yes, it's possible, and also the study was published on this topic. So it's absolutely uneventful, and it's possible to do. Catheterization the same. Enucleation was rather quick, and the same goes for morcellation. It's a good question. It's a good comment. So you don't break the morcellator, you can break the blade during morcellation. And of course, this is an important comment. So when you do such procedures, and we talked with the Yaron about it, so we always ask to bring another blade, and it should be at hand to change it quickly during the procedure. Focal therapy for prostate cancer is becoming more and more widespread. The question, can we do endoscopic inflation after focal therapy? Yes, we can. I did it. after to my patients after focal 9-9-IF, after focal cryoablation. Also, Amy Krambeck from United States, she performed endoscopic ablation. She published this data after focal laser ablation, and it was absolutely uneventful, possible, no complications were observed. Prostate artery embolization, today we'll talk about it. Enikeev will present the data on this topic. So the question is, okay, if the patient have, after this procedure, can we do endoscopic ablation of the prostate? And the answer is also, yes, we can. So, and all the data show that when comparison patients primary and after arterial embolization, all the data functional outcomes are all the same. Urethral stents. We know these patients also. Is it possible to perform endoscopic ablation? I see, yes, you all agree with me. Absolutely, it's possible to perform endoscopic ablation after urethral stents, and we also have these data on this topic. Absolutely uneventful procedure with short cauterization and no complications were observed. Medication therapy. So some surgeons say, whoa, some medication therapy can affect HOLIP, so should we do it? And also studies were performed on this topic. So, and the final conclusion, and of course, 5-alpha reductase inhibitors are in the spotlight here. Are they effective surgery? The answer is no. So inoculation efficacy, morcellation efficacy, bleeding, hospital stay, drug-related complications, no. The next question, prostate biopsy. So we have a lot of patients after prostate biopsy, fusion biopsy, systematic biopsy. Can we do polyp right after this procedure? Professor Stoffer, Mario, what do you think? For sure. So what's the problem? Sure, it's a good question. It's a good answer. So, but there are two different opinions on this matter. In one study, authors said that it's better to wait 6 months after biopsy because the risk of intraocular complications in their study was higher. On the other hand, in other studies show that absolutely no difference. And frankly, I think, please surgeons who perform endoscopic ablation of the prostate, please raise your hands who do not wait any time after prostate biopsy. So yes, most of the hands. We don't wait. There is no need to wait any time after prostate biopsy. We can perform endoscopic ablation. Sure. So is it possible to combine? I am finishing, so I just want to clarify and to summing up. Is it possible to combine enucleation with other surgeries? Why not? Sure. And there are more and more centers who combine this surgery with others. So they do this procedure together and show that it's absolutely doable. No effect on cauterization, no effect on complications. So it's absolutely doable procedure. So dear friends, I'm summing up. So now we see that endoscopic ablation is becoming more and more widespread all over the world, and here in Israel and all over the world once again. Today we will present different enucleation techniques, state-of-the-art holmium laser enucleation, electroenucleation. Is it possible? Of course, and you will see it in one of the best hands in the world. It will be presented by Thomas Kerman. And we also will do live surgery with new thulium fiber laser. It's a new player on the market, absolutely new laser. We will present it and present the procedure with this laser. So don't stop. We see all the advantages of this new method, and moving forward, and the road will appear by itself. Thank you for your attention. Any questions? Any questions from the audience?
Great presentation. I agree with everything you said. And, you know, said 600-gram prostate, 800-gram prostate. It's a bit scary. It takes longer. But as we learned from the open prostatectomy era, the larger the prostate, the more satisfying the plane that we have. Okay, the smaller prostate is much harder to reach a satisfying plane. So it will take longer, but you'll have a great plane, larger prostates.
Absolutely, that's what I was trying to highlight. Can you give the microphone to Mario?
Dmitry, congratulations for organizing this event and for your initiative to make it popular in our country. And you see the interest of the audience coming for that. Thank you for your excellent talk. I just want to make some historical remarks. When Hirokapir formed his first enucleation, he used a probe which was smoothed around, and the enucleation was done blindly with digital rectal assistance. So he was working with one hand and the other hand in the rectum of the patient. And then he completed the enucleation by TUR with the monopolar energy. The results were, the procedure was published in the Nippon literature, which was not exposed to the Western urologists at this time. Later on, in 1996, 1997, when the group from Tauranga, New Zealand, Peter Gilling and Mark Fraunhofer started to try performing enucleation, they adapted an arthroscopic morcellator to a nephroscope to perform the morcellation. And the first morcellation, the enucleation was done transurethral, but the first morcellation was done suprapubic. And they encountered a lot of extravasations and complications. And then they changed the procedure in 1998 when they reported the way that the procedure is done today. Thank you.
Thank you, Professor Sofer. I have to send Dmitry to the operating room. His patient is ready. So we'll see you back again in 40 minutes, and let's move on with our program. We have Fernando Gomez Sanchez ready.
Hello, this is Fernando Gomez Sanchez. I'm going to present a video of a semi-live HOLEP with a block technique. I have to say that I support Israel in the historical moment that you're going through, and I send you all my warmest regards and friendship. The cause of incontinence with the classic HOLEP technique is multifactorial, but the removal of the sphincter's mucosa mechanically during dissection promotes early stress incontinence. So scoring the mucosa at the beginning of the procedure is going to prevent this ripping of the mucosa of the sphincter, and is going to prevent early stress incontinence. And this is what I'm going to show, the unblock enucleation with a progressive and careful mobilization and liberation of the apex to protect the sphincter. I hope you enjoy the presentation. And I'm going to introduce you to the unblock HOLEP, unblock enucleation. In this case, we had a man with a 168 cc prostate, so quite a large one, and there was a lot of bleeding at the apex, which made the apical dissection a little bit more difficult. So in cases like this, what we do is we try to mark at 12 o'clock, just past the sphincter, proximal to the sphincter, to have a reference. And then we go near the barrow to find the plane of the adenoma and dissect it carefully, not pushing too much laterally, so we can see where the posterior edge of the adenoma is lying. Here again on the other side, a similar maneuver is carried out. Opening the plane between adenoma and capsule. And then, of course, we have to try to connect the 12 o'clock mark with the lower aspect carefully to preserve the sphincter's mucosa. The wonderful aspect of this approach is that we will preserve the sphincter's mucosa, and that will provide the patient with immediate perfect continence, and it will reduce the chance of stress, temporary stress urinary incontinence that we have seen with the classic technique. In the classic technique, the dissection of the lateral lobe at the apex is carried out without even looking at the sphincter, and often it results in the deepithelialization of the sphincter. So this is the marking of the white line. So it is a circumferential line that demarcates the limit of the apex with the limit of the adenoma. Then we have to connect both lateral apical planes in the midline by cutting the frenulum of the verumontanum to connect the two lines of dissection, the two lines of attack that we have demarcated apically, and then develop progressively the posterior plane. This development of the posterior plane can be done very fast. It's quite easy. It's important to keep a wide line that goes from side to side because that keeps orientation, and not always we can see a perfect, clear plane of separation between adenoma and capsule, and keeping these lines around the adenoma is going to help us when it is not so clear where the plane is. Here you can see that the sphincter has been preserved. The white line is a little bit more inside, and now we're going to start with the apical dissection. For that, and in order to release the sphincter from the adenoma, we have to cut a little bit in the edge, like deepening the white line that we marked at the beginning, even cutting a little bit on the adenoma. We don't mind cutting for 3, 4, 5 millimeters in the adenoma because that will actually detach the apex of the prostate from the sphincter, and it will give us better access to this plane. I like to do an initial posterior apical dissection and deepen it towards the bladder neck until I can connect with the posterior line of attack, posterior line that we had done, because it's important to be able to go around the adenoma and to have a continuous line that connects the lateral plane with the posterior plane, with the anterior plane. So it's very important to connect the lines that we are developing. Here, of course, we want to protect the sphincter, and as we come more anterior, the cutting has to be a little bit more horizontal. So initially we do a cut, even a little bit in the adenoma, we don't mind, because that will give us some space to access the apex and to develop it carefully with the energy of the holmium laser. In this case, we are using a pulse modulated laser. This is the Quanta system 150 watt laser at settings in 2 joules and 50 hertz with the virtual basket setting. It is a very nice advance in the technology of the consoles that provide excellent first pass coagulation and excellent cutting properties. So it has enhanced the properties of the laser we use for HOLEP. So here you can see the careful ascension. Carefully we have to ascend until we can position ourselves on top of the adenoma anteriorly. When we get to that point anteriorly, on one side, then we have to go to the other side, and this is the other side, the right side of the patient, and we are doing the same maneuver, just coming up, incising a little bit the area here between the sphincter and the adenoma. On the adenoma, we don't mind, as I said, deepening a little bit this incision, because what we are really achieving is disinserting or separating the tip of the adenoma from the sphincter. Of course, once we get the access we want, we can go and look for the proper plane. So often these incisions that we made are going to be removed with the adenoma. So here's the ascension on the right side, and we will try to get towards 12 o'clock, where we will find the anterior 12 o'clock fibers that we will be able to cut much Hello, this is Fernando Gomez Sancha. More horizontal. So initially we do a cut, even a little bit in the adenoma, we don't mind because Hello, this is Fernando Gomez Sancha. I'm going to present a video of a semi-live HOLEP with and block technique. I have to say that I support Israel in the historical moment that you're going through, and I send you all my warmest regards. Hello, this is Fernando Gomez Sancha. I'm going to present incising a little bit the area as we change or as we deepen. This is the anterior dissection, so we can go from side to side. Remember, always we want to connect the lines we are doing so that when we are anterior, we can connect easily with the lateral aspect, and then we can connect easily with the posterior aspect. This is the development of the circumferential plane, the circumferential line of dissection that will take us to the end of the procedure. It's important to position the scope so that the line of dissection is in the middle of the screen. This allows us to see half of the screen with adenoma and half of the screen with capsule. This is the vertical fibers of the bladder neck. It's a pathognomonic sign that if we cut there, we're going to enter the bladder above the anterior commissure. This is the mucosa of the bladder. There are many vessels at this level, so we have to be careful because there is a lot of mucosal bleeding that can make morcellation a little bit more difficult. This is the circumcision or the cutting of the bladder neck circumferentially following the anatomical planes. So all the anterior aspect of the prostate has been liberated, and we are now cutting the bladder neck circumferentially. Here you can see how the camera and the scope have to look towards the line of dissection, the line of attack. And here we can judge the depth of the dissection. And if we're going too deep, we can correct by approximating the fiber and targeting the laser closer to the adenoma. And if we are leaving tissue behind, we can always go a little bit more lateral, more peripheral to try and remove the tissue that we want to remove. Typically, the adenoma looks a little bit more yellow than the capsule that looks a little bit whiter. This is the incision of the bladder neck. When we get to this point, we have to check the urethral orifice to avoid damaging it. And carefully, the energy is used to dissect the anatomical plane. The other pulse modulated technology that has come out is the Moses technology, which is slightly different from virtual basket. And they're both, I think, revolutionizing the use of HOLEP because the quality of hemostasis is much better. You can concentrate on dissecting your plane without having to care for keeping a good hemostasis because it automatically happens. So when you do your dissection, you see the energy reaches a little bit further and provides better coagulation that allows you to concentrate just on working on the anatomy, on how to target laser energy towards the line of dissection or a little bit closer to the adenoma to adapt to the anatomy of the prostate and to prevent going deep in the capsule. Here we managed to elevate the adenoma, push it a little bit into the bladder, and that only gives us better access to the bladder neck at 6 o'clock, where the fibers are cut, remaining fibers. And then, of course, if we keep the same rotation direction, it's very, even very large. And then the 6 o'clock fibers that are to the bladder neck can be cut very safely and very precisely until the adenoma is detached completely and flipped into the bladder. So this took about 40 minutes in this case. We are able to complete these operations in around 1 hour, even for the very large glands. Might need maybe 10 or 15 minutes more than the smaller. It's important to coagulate the mucosal vessels. Can bleed, and they're a little bit difficult to see sometimes because they turn towards the flow of the scope is pushing them inside, and we don't see sometimes coming. So we have to pay attention to the mucosal bleeders. And here you can see the excellent procedure. A little bit of hemostasis has to be carried out in large glands, and not so much in the smaller glands. And then the other important aspect of enucleation is the teamwork. You need to have properly trained nurses that can do fast, very proficiently, because you might need to use a resectoscope to change to the nephroscope, that morcellation. If the morcellation has a malfunction, they need to know how to type fast, and this patient becomes small. That we can do 5 cases in one session from 3 or 4 p.m. to 9 p.m. 1 hour per patient, including the change of the patient in the operating room. So many times for 60, 70 gram prostate, we can use even 20-25 minutes. Morcellation has to be with care, but lead of the procedure. And I hope you have enjoyed this video. There are plenty of full-time videos in my YouTube channel that you can find easily online. And want to learn. Advice is watch a lot of videos, learn the anatomy, and you will be able to learn for sure to do HOLEP. This is the tissue, this is the color of the urine procedure. So thank you for your attention, and I hope to be questions in 4 minutes. Cannot hear you.
Very much, Dr. Fernando Gomez Sanchez, and for a nice presentation. And really, when I started, I looked at more videos and really learned a lot. Did improve my continence rate. So, any questions from the audience? Or maybe I can ask a question. I saw that you were using a 26 French Wolf resectoscope. There is a 24 and even a 22 French. What do you think about smaller size resectoscope?
I think it's a very interesting development. And it would be very nice to have different sizes of endoscopes to try to adapt to the patient you're treating. In our environment, I think most patients accept very nicely a 26 or a 24.5. And also we have to see the reality of our work. We do these very long lists. Today I'm going to do nine HOLEPs. So I think up to now, having the 24.5 and the 26 have worked very well for me, but I have to accept that sometimes having a smaller scope could generate a little bit less trauma, and it could be a good option for selected cases.
Hola, Fernando. Thank you for your presentation. Ilan Kafka, how are you?
Hello, nice to see you.
Nice to see you. Beautiful surgeries. always. Any tips of trying to avoid? I asked earlier before. You might have a large median lobe. You might have very close to the bladder neck the UOs, or you don't see them. Do you care? Do you just go and enucleate? Do you have any tips to avoid shaving the UOs when they're very close to the bladder neck? Anything you want to comment on that?
Yes, I think you have to try to visualize the UOs and try to protect them. It's true that if you hit a UO, probably nothing will happen, but I like to, as you saw in the video, I'm sorry that it seemed that it didn't work very well, but in this technique, you do the apical dissection from 6 to 12, and then on the other side to meet at 12. And when we do the bladder neck, we do it from 12 to 6 in one side and then the other side. So when I reach 4 o'clock in one side and 8 o'clock on the other side, I just go in with the cystoscope to see, and then I can try to avoid and try to protect the UOs. Sometimes, in some cases, it's very difficult with very large middle lobes. Sometimes they are elevated by the middle lobe. But in principle, I think we have to be careful with everything we do. And most of the times, I think we can carefully manage to protect the UOs. It's not very difficult.
Okay. Thank you very much. Thank you very much. And
Thank you. Thank you. And congratulations.
So we'll move to Dr. Thomas Herman.
Thank you very much again for the invitation and to be able to present this technique here. I think we basically see everything, because as Dmitry just said, enucleation is enucleation. That is still true. Whatever the market throws energy sources at us, it's the same thing. And therefore, I will current-based techniques, which is the origin of these techniques. And they are not old but gold, but they are modern techniques. And because in the end, it's anatomy. Yeah, and I would like to start my video now. You have the video. Please start the video so that I can comment on that. These are my disclosures. I have developed this probe together with Karl Storz, and I also invented the TULAB years ago in lasers. This is the setting, so we use lowest for coagulation, and we do VAPO resection level 4. This is the theory of my technique. We have to preserve the lysosphincter, or better, we have to preserve the distal urethra. This is why I'm speaking of urethra sparing, because we are not only sparing the mucosa, but also the submucosa, which contains the lysosphincter. And if we look into that, it's very simple, because the anatomy is very simple. We have to keep the 1 centimeters, 1.5 centimeters above the collicle. That's it. That's the patient that you will see. It's a small prostate, 50 ml, and a typical patient, if you wish so. And nothing special into that. And he had a wish, of course, for ejaculation sparing. This is what it was in the end, 25 minutes for this patient, and the outcome was as such. So now we're going to the, I always do insertion of the video, okay. I always do the insertion of the sheath under vision, because you can rule out any additional anatomical problem for the patient, especially when it comes to the very rare situation of urethral stricture after surgery, even with 26 French. I have never had the urge to switch to a smaller sheath, and I'm doing this now since 2007. This is a probe, which you can see I'm using 30° down, and Fernando already told about the incision lines. I will demonstrate my perception on how I perform incision lines. So it's 1 centimeter above the collicle towards the bladder neck. This is the probe. I always say just consider it as a wide beam of a laser probe. The difference is that you have better hemostasis than with a laser probe. This is my incisions I do. You see, I always stay above the collicle, as you can see here. And there was the question that will for sure come later on, is this still anatomical enucleation? Of course, this is, because enucleation, this is the 12 o'clock incision, as you can see here. I do midline incision, which I will come back later, because I believe, and this is how I teach enucleation in my setting, because I don't have such a nice YouTube channel like Fernando, which I always ask people to watch once they start enucleation in my center. It is what I do for early submucosa and mucosa sparing. You can see that we are quite above and towards the bladder neck, because I want to see this round mucosa and submucosa patch preserved right from the beginning. And as said, I'm doing a 12 o'clock incision. And this is not because for this small prostate. This small prostate would go through the bladder neck easily. But I'm teaching is, I make it a point that we do everything, at least try to do everything in the same manner. And this is why I say I would like to do an en bloc technique, but I would do a median incision, because I can push the left lobe in just in the beginning. And if I have a very large prostate, I can push them serially through the bladder neck, and I don't feel the urge to incise the bladder neck at all, because as you all know, in the bladder neck is the musculus sphincter detrussae, which is the internal sphincter, and we don't need to incise that unless the patient doesn't have a hypocontractile detrusor or an acontractile detrusor. If this is visible in your dynamics pre-surgery, I'll do that, because then we would see bladder neck contracture, because the musculus sphincter detrusor has a tonus and it will not be blown apart by voiding because of the hypocontractility. So we need to incise that to prevent a bladder neck sclerosis. So you can see here, this probe is really a mechanical splitting probe. I always say, like scratching with a fingernail. Plus what you saw there, if you have small nodules in a multinodular disease, you can nicely vaporize. So this is a mechanical vaporization and dissection probe. It goes very nicely in most of the times. I prefer using bipolar, especially in patients under anticoagulation, because the coagulation depth is a little bit deeper and more firm than in lasers. So that's very nice. So you could see it's almost, we have reached the convexity already on the left side. So I just now try to loosen the left lobe, also ventrally, and then push it through the bladder neck. So that is what I do. This is why I have split the adenoma in the commissure anteriorly, in the fibro-anterior stroma, to facilitate that. And that is basically what I'm doing here. So see, I'm finalizing the fibro-anterior stroma cut to remove the left lobe, not remove, but to loosen the left lobe, to push it through the bladder neck. And then I just have to concentrate on the right lobe, and I don't have to push the right lobe against the left lobe anymore. I always say to the people that come to my place, have you seen two fat men wanting to cross a door, and they never try it at the same time? They do it one after each other. And this is very true for bladder neck preservation and big prostate. So this is why, think of the fat man and that go through a door behind each other, and then you know why I split the adenoma. You can see here, now we've reached nicely the bladder neck is preserved, and I'll take out the adenoma now. I like the probe not as the only tool that I use, but it is a sufficient tool for all prostate sizes. So you could argue whether you're faster or not. I believe that it is as fast as the fastest laser probe. It is just a matter on how you are adjusted your technique towards this probe, because again, we are doing the same thing like we saw with Fernando just a few seconds ago. What I prefer to start teaching enucleation with bipolar, because this empowers the people who want to learn enucleation to switch now to bipolar sling. So I'm using reusable sling. This is so far a reusable sling, and it is providing what people who start with this technique urgently need: good vision. So this is the vision you have. You can go immediately for coagulation once you have split the layers and see the anatomy. So you can straight go for coagulation, and you will always have a nice layer and good vision, because that is, I think, paramount in the beginning. So that's almost done now. I'll do it very diligent because I don't want to see perforations, not because I think that they are so terrible, but I don't like bleeding. And the other thing is the less perforations you have, I believe, the less irritation you have. So this is why I definitely try to avoid that, especially at the bladder neck. You all know this from radical prostatectomy, and Javier will show it to us again. It's about no urine extravasation. So I always tell patients with a high rate of irritative symptoms upfront surgery that they will face an increase of that most probably after surgery, not only because of the wound healing, but of the periprostatic inflammation that will take place as well. And we want to minimize periprostatic inflammation after surgery by not perforating anyhow. Yeah, of course, and the bladder neck sclerosis is something we should definitely avoid. For large prostates and small prostates and prostates with big median lobes, I always advise not to come from below. So I have some different experience in the past, like Fernando, but everybody does it according to what they have lived in their past. I always try to do this from the side, because I think that is the best idea to avoid damages of the bladder neck, to do the bladder neck, to do the side lobe or the bladder neck from the side, because that is what you would do with your finger, you know, that's with the finger. And you see here now, I'm pushing in the left lobe now, it's in, so I'll not have to take care of that. Plus, I can do a nice and swift preparation from the midline towards the left, to the right side, because I don't need to search for new layers. And with regard to the question that will arise, is this anatomical enucleation? As you have seen me cutting the mucosa quite proximally, of course, because you see, this is the entire transitional zone. We don't want to attack the peripheral zone. This is the entire transitional zone, also at the apex. So this is, of course, anatomical. The only thing that we preserve is the mucosa and the submucosa containing the internal sphincter, the lysosphincter. We have to cut the longitudinals, but we maintain the circumferential, and that is the buffer which we need for passive continence. And now we're going to the right side, and whatever I do, I always go around the mucosal rim once again and make sure that I don't tear it at the end, because that would be a very foolish thing to do. And after that, when it's loosened, I start again engaged in mechanical preparation. As you can see here, now the mechanical preparation starts again. We have a little bit of prostatic inflammation on that side. So this is why we have micronodular disease. So that needs to be put out. And this is what you nicely can do with this vaporizing features of this probe. This probe is convex towards the tissue. So this gives a good contact towards the tissue, and that's it. So we are now doing a little bit of vaporization there. And you can see now this is the improved layer, more proximally, and now we're trying to encircle or dance around the adenoma, as I called it when I was doing a lot of SULAB with the continuous wave laser. I'm now doing it with the continuous, not continuous, but the pulse Tumyak lasers. We have not heard about that today. I think this is also a very nice energy source. You can see here, I'm trying to be as anatomical as possible. This is again a 50 ml gland with some prostatitis in the past. So we have some micronodular disease. So we need to take care of that as well, because these micronodular disease will be the origin of potential recurrent adenoma. So we need to make sure that this is all out. And we're almost done here. So if you see that layers, this is like, again, scratching with a fingernail, then you are sure. This looks like mucosa. If you completely bluntly dissect that, this is what I like, and this is what I like to teach with people who have never done enucleation because then they easily recognize the layers, the thermally unaltered layers. Yeah, so we're almost done. Again, we are doing the midline from the side for the same reasons. If you are right-handed, you do the perforation on the right because of the management of the working element, so that you have to go either on this or this. So this is why the best thing is to do everything from one direction. And as you can see, I'm always perpendicular to the layer of the peripheral zone, because I believe that this is the best thing to do. And especially if you work with a splitting wedge like this, you need to go into the right direction. Otherwise, you might do some foolish things. Again, I don't believe that a lot of energy at the bladder neck causes the bladder neck stricture. I think it's, first of all, perforation. And second of all, it is hypocontractile dechusa or pre-existing prostatitis, especially the bladder neck, close to the bladder neck prostatitis. We see that today nicely with MRI. With ultrasound, it was not so visible at all. But with MRI, we can do a lot of counseling before. And if I have a last prostate, I definitely always want to have an MRI, because I need to see more before I do the surgery. So as you can see here now, I'm now putting in the whole adenoma. There was not a single point where I would have started to consider whether I want to dilate or incise the bladder neck. So I'm just looking that I'm not leaving not just a single thing here at the bladder neck, and try to do coagulation so that there is actually no irrigation necessary after surgery. This needs some attention, but as I've said, this 50-gram gland in total, starting till catheter, needed 24 minutes, so just 5 minutes more than this video. So that is a competitive time. You can't do it much faster with a laser, I reckon. And that gives the same result as you said. It's completely bloodless, as you can see here. And what I always do is I do a complete inspection of the fossa before I leave it and go for, and that is the complete, as I said, you see it comes down because, of course, of the longitudinal fibers of the submucosa. It of course goes down. Yeah, so this looks like we have incised 1.5 centimeters above the collicle, but it seems to have shrunken. But this is just because of the contraction of the longitudinal fiber of the internal sphincter. So that is morcellation with a drill cut from Karl Storz. I love it, as well as I love the other rotating from Wolf. I have been working with Wolf in Hanover, where I developed SULAB and BipoLab, and now I'm working with drill cuts at 6 years. It's nice. It's at least as fast as the Wolf, has a better suction from my opinions, and you see it's bladder neck preserving. So why I'm doing this now, why I'm bringing back this probe, because this is the best invested minute of your surgical time. I do this always, and I teach it, and I come into the OR if somebody has started learning curve to see whether they do it, because I don't want to see bleedings. And that is the best thing after a collapsed prosthetic fossa, to go around the bladder neck and do this final coagulation. You will see no bleeding at all. And then you have the final inspection. And again, this is the complete urethra with a submucosa, and that will have immediate continence. That was it. That was bipolar in urethral sparing.
Thank you very much. Any questions from the audience? So I have one question. How, if you have a bladder neck stricture, how would you deal with it? Do you incise, do you inject, or what is your treatment option for bladder neck?
Thank you very much for the question. So fortunately, we have very rarely bladder neck contracture. And if we have, we mainly have it in patients with hypo or acontractile detrusor, which happens quite a lot. I'm working in a region where people seek medical help for bladder benign prostatic obstruction very lately. They have large prostates and they have a high rate of urinary retention. Last week, I had a patient with 3.6 liters of acute urinary retention. So this patient has a destroyed bladder. What do? The first time I do an incision at the bladder neck at 5 and 7 o'clock if it happens. If it happens for a second time, I learned from the PubMed that I should inject triamcinolone. And if that doesn't work, I have learned I should try Optilume. I have not tried Optilume for bladder neck contracture yet. So far is that I have done in 2 cases a complete prostatectomy. So resecting the prostate completely with a robot and do a new anastomosis for the urethral stump and to the bladder neck, and that helped the case. These were 2 external patients that I received with this question, so I did that. It works very well if you have a patient after enucleation, if you have a patient after TURP, especially monopolar TURP. The resection of the prostate and leaving a urethral stump is quite complicated, but after enucleation, I've done this once in Hanover. It is very easy and solves the case. So again, I would incise at 5 and 7. By the second time, I would do triamcinolone. If it doesn't work, I would probably today go for Optilume as a third try. And if that doesn't work, I would definitely go for not salvage, because it's not salvage, but I would resect the prostate completely and do a new anastomosis. I'm not such a fan of Ypsilon V plastic in bladder neck sclerosis. I tried this a few times and it was not so, let's say, I didn't like it. And if you know how to do a radical urethra sparing prostatectomy nicely, you can do that with a good effect and with a good continence result. That's what I do.
Okay, thank you very much. Dmitry is ready in the operating room, so stay with us, Dr. Herman. And we'll go to Dmitry. Hello, Dmitry.
Yes, Yaron, can you hear me?
Only
Perfect. And can you see the endoscopic view?
Not yet.
Not yet. So, okay, so before we start to go to the endoscopic view, first of all, dear colleagues, welcome to our operation unit, the operation unit in Hasharon Hospital, Rabin Medical Center. I can tell you that I operated in many clinics all over the world, but here in Hasharon, it's, I think, one of the best operation unit in the world. So, welcome. And before we start, so a few words about the equipment that we use. So today we use 24 irrigation resectoscope for endoscopic inflation of the prostate. morcellator from Wolf. It's a piranha morcellator. And the laser, can we see the laser, Yaron?
We can see it from behind.
Okay, so it's a new thulium fiber laser. This one is from the company Olympus. So once again, it's an absolutely new generation of lasers. So first of all, dear colleagues, you can see how small it is. So it's absolutely like you can compare it to what, like a size with a microwave.
We can now see the endoscopy.
Perfect. We will slowly move to it. So a few words about the laser because it's really very important and it's absolutely new to Israel and urologists, but it's also new to all urologists all over the world. So this device, first of all, you don't need any special adapters. You can just easily plug it into the wall. So it's a small size. It's like a comparison of all the modern computers. So dear colleagues, welcome to the future. The modern computers, the modern lasers are here now. You can see that. So an important advantage of this laser, especially for stones, that you can use smaller fibers. We know that to Holmimiak laser, 200 laser micron is the minimum we can get. So with this laser, we can use up to 50 micron laser fiber. And of course, in the era when endoscopes are becoming smaller and smaller, of course, we need laser fibers that would fit them. And so this is the new generation. So we have laser fiber. Now we can slowly move to the endoscopic view because time is of the essence, so we should be in a hurry. Do you see the endoscopic view?
We can see it clearly.
Yes, so we have a patient, his prostate volume is 80 cubic centimeters. So there is no median lobe, we have lateral lobes here. So what we usually do, frankly, we talk about orifices. I absolutely don't worry about the orifices. So, and usually it's just for you, dear colleagues, I prefer to find it, it's something like a small, look like a small changes, maybe afterwards we will take it. So usually I'm absolutely don't worry about the orifice, and here's another one. So because why? Because we know due to penetration type of lasers, if we damage ureter orifice, nothing will happen. And we conducted a study on this topic, and we found that there is no need for standing. We just monitor these patients, and that's it. So what we usually do, so this is the verumontanum, this is the lateral lobe. We start incision at 6 o'clock position and make incision from the bladder neck until the verumontanum. So this is the verumontanum. When we come close to verumontanum, we make this incision first under the left lobe and try to connect these two incisions. So once again, you can see how effective and at the same time delicate the laser incisions are. So just I remove the leg to make it more easy for me to move. So what we try to do, we try to combine mechanical movements and laser energy and connect these two incisions. So when we come close to the capsule, we will see the white tissue with the vessels. Here we are. So when we, the penetration depth of thulium fiber laser is just 0.15 millimeters. So it allows you to control the penetration depth. And here you can see this white tissue. And when we see this white tissue with these vessels, we just do mechanical dissection and remove the adenoma. And you see how easy it is. So how easy we can remove it. So now we open the bladder neck. Now we do the procedure with general anesthesia. We can also do it with spinal, and it's absolutely not a contraindication. So just for the conference, we discuss it with the patient and choose the general to make it easier for us to discuss all the issues during the procedure. So what we do now, we try to connect all these incisions, this incision that we make, and so we connect it. So the settings for the laser are as follows. So the energy is 1 joule and the power is 45 watts. So these settings, 45, 50 watts, these settings we usually recommend for enucleation. At the same time, for the beginners who start the experience with this laser, I recommend always to start with 25 to 30 watts. So to decrease the settings. Why? Well, because it takes some time to feel the laser. It takes some time to feel the laser. So that's why you will work a little bit slower, but you will see less carbonization. And that's why we recommend to decrease the settings. And once again, if we talk about functional outcomes, we already said that they're always the same, no matter what kind of energy source you use. But at the same time, regarding the learning curve, we conducted a study. And I took 3 residents. I took 3 different energy sources, electro, holmium, thulium fiber. And we saw that for the beginners, it's easier to learn endoscopic nucleation with thulium fiber laser due to its perfect cutting properties, and second, due to its hemostasis. So once again, perfect hemostasis, and you don't see any bleeders. Once again, and during all the bleeders, we just immediately coagulate them, and that's it. And usually the procedure, if we talk about 80-gram prostate, usually the procedure lasts 25-30 minutes. So it's usually very, very quick one, and we don't need any special additional time for that. So we clearly see the capsule. We help ourselves with the mechanical movements, and you clearly see the capsule during all the procedure. And you don't see a lot of carbonization. So once again, what is important is always to see the capsule. And I strongly support the concept of enucleation, not when we just remove the adenoma and leave some part. So if we leave some part of adenoma, there is high risk of relapse. And that's why the risk of relapse will be higher. So that's why we try to remove all the nodules. So you see, dear colleagues, now we closely move to 12 o'clock position. This is how the prostate bed looks like. Coagulate the vessels. And clearly see all the capsule, clearly see all the plane, all the prostate plane. So, and separate adenoma from the capsule. Once again, what is here we see some fat, but believe me, it's absolutely, if we see, here is the capsule, here is the capsule. So it's absolutely superficial. So the surgeons who usually do 2RP, you can say that, wow, what is going on? This is a fat. But once again, this is a minimal penetration depth. In endoscopic enucleation, it just showed me that I'm absolutely following the plan, and I'm absolutely doing radical procedure and remove all the tissue. I don't leave any tissue. It's absolutely not a dangerous move. It just showed me that I shouldn't go deeper, but you see no bleeding, nothing. The cauterization time will be the same, and everything will be the same, and I'm absolutely not afraid of this move. So you see, this is the adenoma. So now we slowly move to the right lobe. There are different techniques are possible to use for endoscopic enucleation of the prostate. Classical free lobe technique, when we remove, at first we remove the median lobe, after lateral lobes, one by one. Now we perform 2-lobe technique. It doesn't matter for me if there is a median lobe or there is no median lobe. I prefer to do this. Yes, I prefer always to do 2-lobe technique. So now you see the vessels. Dear colleagues, there are 2 pedals on this laser. So we can use 2 pedals, one for cutting, and manufacturer recommends to use another for hemostasis. And I always use one pedal during all the procedure. So if I need to do hemostasis, look here. I just make the distance between the fiber and the tissue a little bit bigger and use the same settings. It's like, I always say, it's like driving a modern car, modern Tesla. You don't need 2 pedals. You can drive modern Tesla with 1 pedal. You just control all the speed with 1 pedal. And the same you do with modern lasers. So you use 1 pedal, and what you need for hemostasis is just to make the distance between the fiber and the tissue a little bit bigger, and that's it. And that's it. This is how it looks like. So now I make several incisions inside the adenoma. Why I usually do that? So to make it easier for morcellation blade to catch it after I remove the adenoma into the bladder. So this is the verumontanum. Now I turn that once again. I turn the endoscope 180 degrees counterclockwise. Move it. Yes. Yes, I can. You're on.
The left lobe. Can you show to the right lobe? Sorry. Can you show us the approach to the apex? Are you doing an apical release, or you just enucleate as you go? Very fast here.
I will show you in a minute. So I will show you your own just in a minute. I make incision. So as it's two-lobe technique, I make this incision at 12 o'clock position. I'm absolutely doing it fast. I'm not afraid. Why? Because I have already separated adenoma in this area from the capsule, and I'm not afraid of moving so fast. So I just remove it and make this incision to separate one lobe from another. You see, so we make this incision, continue doing this incision. I always tell my residents, so when you, this surgery is very nice when you do it quickly, when you don't stop and don't lose time for anything. So once again, this is the verumontanum. You go at 12 o'clock position and continue doing this incision, separating right lobe from the left. Now we separating it. So I have to make a special angle here to separate these lobes. We are here. Okay, we are here. Okay, so we're here. Now, this is the verumontanum. This is the lobe that I want to separate. And you can see here, you can see the veil like piece of tissue, you know. So this is the sphincter. So what I usually do, I don't remove adenoma here. I leave it. I go down. I leave a small veil like piece of tissue because I want to prevent sphincter. And all the separation of adenoma, I did it mechanically here. I did it mechanically. I didn't use laser energy at all. So just to coagulate some vessels. So now what I do, so this once again, this is this veil. So I go down here, and here I remove the adenoma. So I make incision here, and once again connect it with these two incisions. The incision that I make at 12 o'clock. Here, this incision. Continue doing that. So once again, this is this lobe. So regarding also electrocautery, so this is also my rule, and this is the rule that I also recommend for all the residents and the beginners. So you can do any procedure with a laser, but you should always have electrocautery at hand. Sometimes, very seldom, but sometimes it happens, there is such a bleeding that you cannot stop with laser. So for that reason, so we remove the adenoma, this part, into the bladder. So sometimes you need to stop the bleeders. You need to stop the bleeders with electrocautery, and that's why this is my rule. No matter where I do the live surgery or standard procedure, I will always combine it with I always have electrocautery. Once again, this is the verumontanum. What we do next? We make incision here. So if we try to preserve reticulation, so and Professor Herman just showed us, we make incision a little bit closer to the bladder neck here, leave some tissue here. But frankly, I prefer to remove the adenoma, and we will talk about it during today's meeting, how important for our patients to preserve reticulation. So how do our patients really need it? And I hope we will get an answer today. So once again,
Dmitry, so
yes.
Another question. You have with you our fellow, Rabin, who really picked up the surgery quite nicely. So what are your tips for the beginners, how to start his learning curve?
Yes, so frankly, I think it's one of the most interesting questions. So first of all, I recommend to start with a glance from 50, 60 grams to 70, not larger and not smaller. So we discussed it today that small glands, you see there are several nodules here. So we know that small glands are not formed and it's not so easy to separate them. Huge glands also may be too challenging. So I recommend to start with rather small glands. So another question, do we need 2RP experience to start enucleation? So the answer is no, we do not need it. So I know that some surgeons said, yes, you need it because sometimes you have to remove 2RP during enucleation. But I like the answer that Professor Andreas Gross from Hamburg question. So now we have the car with automat. Do we need now to learn how to drive with manual? No, we don't. We don't see any cars with manual. So we drive with automat. Why should we learn with manual? So the same goes to lasers. So you, of course, you have to know how to use the loop, to coagulate, to cut some tissue, but to know 2RP, no, you don't. So, but at the same time, you have to start with this, and you have to have this equipment during the procedure, during your surgery. Next is, of course, the mentor. So I strongly recommend to start the procedures with a mentor. So try to find the mentor for first procedure. So visit the clinic, learn for this. Afterwards, invite mentor to your clinic. Do it together with the mentor. So the mentor should always stay close to you and to help you in difficult moments, especially during the first 10, 15 cases. I think this is the main issue. Next, watch YouTube videos. So now and today, Fernando Gomes-Sacha told about his channel. All the surgeons have their own channels, YouTube channels with the video when they show their techniques, describe it. So, and watch this video. Of course, read all the articles. What next? You should know how to work with the equipment. So you should know your equipment very well. You shouldn't look at the equipment. So as I usually said to my residents, you should know your equipment like, you know, like a soldier know his or her gun in the army. You shouldn't look at it. You should work all the time, look only in the screen. So you should feel your endoscope. Understand what happened if something happens. So this is very important thing. And before you start the procedure, you should work, select the instrument, feel it. And this is also very, very important things to start. So I think now I always prepare the morcellator at the beginning because I think in 10 minutes we will move to morcellation. So we continue enucleation this low. So moving retrograde. Once again, I am not focusing on urethral orifices. And if we look at all experts from all over the world, they are not interested in orifices. Of course, I don't have a goal to ablate the orifice, but at the same time, I know the speed of my incisions, and I know that if I know how quickly I move, so there is no need for that. So now I try to find the capsule here. Here is the capsule. Try to remove it. Here it is, and to combine all my incisions. And finally, I will try to remove all the nodules. So important advantage of thulium fiber laser, once again, if you lose the right enucleation plane, due to its perfect cutting properties, you can always do it. So you can always find it and make this plane. And this is important advantage of this technology. So when you see white tissue, it means that I'm in the right enucleation plane. And here I am. So white tissue, right plane. White plane, right tissue. So, and this is what I want to do. This hand, I always try to put it up, so don't make me difficulties during my movements. This is the adenoma. So once again, when I work near the sphincter, I always do only mechanical movements. And it's very easy always to separate adenoma with mechanical movements in this area. And it's very important to find the plane in this area. So this is the area that I need to see the right plane during the procedure. And this is what I usually do. So 80 gram, it's a good gland for live case surgery. So together with Mario and Yaron, we were in Salzburg during endoscopic meeting with our friend, Professor Lucas Lusardi. I did a live surgery there for 140 gram gland. And of course, it's not for live surgery because it's take more time. But this procedure, we're slowly moving forward. So this is the capsule. So once again, 10 minutes, and we will move to morcellation.
All right, thank you very much, Dmitry. We have to carry on, so please finish the surgery safely and join us back to the conference hall. So we will continue with the next presentation.
Thank you, Yaron, and good luck, and see you all, guys.
Bye. We have now Dr. Kevin Zorn, techniques and presentation of long-term outcomes for the Zoom. Is he ready?
Yes, my video on here.
Okay, thank you very much and welcome to our conference hall.
Here.
So good evening to you, Dr. Kevin Zorn. Can you hear us?
Yes, indeed. The wee hours of almost pushing 4 a.m. here in Montreal, Canada. So just wanted to take this time to thank you guys and for the organizing committee to having me partake in this event and to share amongst the global leaders in BPH. And as we're saying, times have changed not too long ago that we didn't have our tool shed was quite small and our options for our patients. So let's share screen here. Can you guys see or?
Only you need to share the screen.
Yeah, let me see that here. Zoom. Check screen. Now I'm talking. All right, can you guys see everything?
Yes, we can.
Perfect.
Here. Well, as I was tasked to do here, to shed some light on office-based resume technique and some of the outcomes in terms of long-term data that we have and still remains as the pinnacle data from the initial study. So we'll cover that. Here's my disclosures, just some of the work with various BPH technologies. You know, just part of my involvement with some of the guidelines for CUA and the AUA. And, you know, the very early years of my career, I actually learned how to do a hole-up way before even doing TERPs as a med student with Dr. Alali. So, so part of my thoughts and involvement with any of these BPH surgeons, I still hear him always asking me to look for the capsule, understanding that from a very early element of my career. So the first thing, just, you know, if we take a pause and think, you know, it's not too long ago that, you know, maybe 3 generations where, you know, BPH wasn't much of a problem. So I call BPH the new old problem because it wasn't until the turn of the century where, you know, we would even get to an age as a human species to be even in the PSA screening guideline ages. So, so certainly, you know, the length of life has been one of the issues that says that, you know, as we continue to in our longevity, bring us to an age where, you know, BPH and what I call prostate puberty continues to become more of an issue. And we know that as a community of urologists that we don't populate the urological numbers as much as we need to match what we're going to be in the next decade of life. So, you know, if we look at the next 10 years, both US and the rest of the next couple decade, that the men and humans over the age of 65 will double or triple. So there's going to be a lot more humans, potentially with larger prostates that we have to manage. And I think coupled with our pursuit for new, less invasive, quick remedies for BPH, fills that new gap of the mist. And so I guess amongst the talks today, I'll be cracking the ice with mist, looking for an off-the-shelf potential, short, quick, the Amazon Now fix that will give us a delivery of therapy that is improving urinary flow, but at the same time not down timing the patient. And we now have on the armamentarium on our portfolio of menu, we have since 2013 the UroLift. Dr. Alterman will be presenting on that next. You have the steam injecting heat and transfer of energy into the cells and inducing cellular shrinkage and actually making a difference in the prostate volume. You have the iTind with now Optilume, and finally the paclitaxel balloon for Optilume BPH. And I think as a urology community, just to preface in here, we've also become not just better radiologists with some of our focal therapies and what have you. I think we're also becoming more comfortable as a anesthesia team and being able to deliver various periprostatic blocks, various types of sedations, or inhaled products, which when you do resume, so for those who've done resume, sometimes it takes longer to do the setup and the anesthesia than actually to deliver, the several injections of 9-second therapy is a short-lived procedure. So having these opportunities to do those, I think, makes us able to do these technologies in the office setting, which is to me the goal of pursuit of mists. So in Resume, we're using, kind of a modified cystoscopy and using this, rigid disposable scope to inject, just puncturing beneath the mucosa and delivering for 9 seconds. It's 0.42 milliliters of steam, or 208 calories. That in that transfer of energy formation from gas to a liquid, that passage of that energy will induce this zone, usually about 2 by 1 centimeter ovals overlapping from the bladder neck to the verumontanum. That energy that will then slough or shrink, and there will be some degree of a reopening, a physical change to the prostatic, fossa. So that's what we want. We want to get rid of that, flow is pressure over resistance. Can I reduce the resistance? Is it as much as a hole-up or so forth? No, but how much is enough to get someone to do what they need to do, but preserve some of the other functions, particularly with ejaculation. So what's unique here is that we're using finally a new type of source. It's a steam. You're using water. You're allowing the transference and convection, and it's really contained in this box, that the outer capsule that we surf along for enucleation. But we're going to use that now to trap in the heat. That will allow that energy to do its work and not go beyond. So, other than now they're using Francis Medical, using these longer needles to get into deeper areas for maybe prostate cancer. This is really meant to be, contained into the transition zone only. And so once you partake on Resume procedures, you kind of, is it 1 injection for every 10 cc's of the volume of the prostate? Or does it really have to do when you're doing your periprostatic block? I will always look at that length from the bladder neck to the apex and calculate out for every 1 centimeter. That's where the number of injections you're going to be doing. So you're planning ahead. Is it a even number, or are you going to save 1 or 2 injections toward as well the middle lobe, or a high median bar? And I think that's the nice thing. You have one device, which in a Canadian culture, can you get the most for your device? So that device of a Resume gun with the box gives 15 injections of 9 seconds. And if you do a couple of 8 seconds, you can, push that a bit beyond maybe 20 injections, but, you don't want to be doing the full 9 seconds. But again, 1 gun per 1 human, versus some of the UroLift or some of the others do need much more carbon footprint of materials. And there's no foreign body that's delivering. It's steam. It's, all natural. And looking at the first-in-man MRI studies, well, hey, if you do this technique, then we've seen that we're able to shrink the prostate in, the realms of 30%. And Dr. Alterman and myself, we've actually looked at some of the 12-month data of patients undergoing Resume, and using ultrasound, seeing that there is a bit of a range, but in general, about 34% of patients, 34% volume reduction across the board for the volume of prostate, irrespective of the number of injections. So the whole idea that, do we need to do too many injections? Could we be adding to the delay in recovery, or potentially having more irritative symptoms, or the whole adage now of less is more? So again, Resume, looking at the 5-year data from the Pinnacle, which remains the longest term data that we have with clear outcomes, really shows here that amongst the MIST, I think it has the least, retreatment rates. And if anything, if you look at them, most of them is the first 1 or 2, 3 years. That is it because we didn't do enough treatments? Was it inexperience in the learning curve, or just we're dealing with a different type of tissue? And we'll dive into that after, but stromal versus glandular, there's some differences between these patients. That does the steam diffuse through equally for every prostate? We'll dive into that after. But at the end of the day, amongst the MIST, it probably, I think it has amongst the lowest retreatment rates, and it's the only MIST that you actually create a physical change in the volume of the prostate. And you'll see, as I quote patients, just 4.5% at 5-year retreatment from surgery, and medical wise, that the need to go back on medical therapy, about 11%. And so, you're going to see a wide variety, but ultimately, if you were to scope patients after these procedures, which some of us do, I find there is some sloughing. These patients do have a bit of a journey, I like to say it, from the time of treatment. It's not Amazon now. You have to make sure that's very clear in the discussion with patients. There was a first inflammatory reaction that's going to need to be worked through, and infection or potential recatheterization. But once you get through into the 2nd, 3rd month, that's where the, like running a marathon, you cross the finish line. Median lobes, it's amongst the MIST. Usually middle lobes are exclusion. You're not supposed to for UroLift or iTind. But with a Resume, you're able to manage those and use your needle very specifically to puncture in and use that ball of tissue, typically much more stromal or glandular. You'll able to create a big impact. And you'll attack it usually from its sides, so that you're well away from the trigone, and you're delivering that energy in there. So it is something that's doable and has a great response to that. And for those who've not done this, it's a modified cystoscopy. You see what you're delivering. You are able to modify your technique based on the size and length. Some of the tricks and tips for the middle lobes is really trying to visualize what you're managing to inject, and you don't want to be too close to the trigone, so you'll be able to back up and deliver those angles, usually 45-degree angles, into the deep sulcuses of that middle lobe. Planning ahead, like anything else, the 5 Ps of urology is planning and preparation, prevent poor performance. When you're doing your ultrasound, when you're about doing your cysto, have a field idea that every 2 fields of vision is 1 centimeter. You can pull back, be at the time that you insert the handpiece, or when you're in your truss. If you do that for your anesthesia, using those cues that get an idea of how many injections you'll do. Because once you start injecting, if you don't have a very sequenced manner, you won't necessarily see where you punctured or injected last. So you may tend to want to over-treat because, well, I got 15 uses, might as well bang these out. They're 9 seconds each. You'll be done in maybe 4 or 6 minutes, but you don't want to add too much, because then you'll create much more inflammation to the patient. So that whole idea of avoid over-treatment, stick to the 1 centimeter rule or field of visions, and adding too much steam doesn't necessarily mean that you're going to get a bigger difference. And Dr. Altman and I and some of the other publications validated that as well. And so, I think, if you look at a lot of the outcomes, we'll look at it together. No one really looks at the 2 and 4 and 6 weeks after this procedure. There is quite common that inflammatory response. I think everyone here is at some point you burnt yourself with cautery or a laser. It takes a little longer to heal than maybe a paper cut. So that's the difference here. You have steam, it's heat, the human body, and the macrophages need to do its work. The inflammatory response is there. And I call it sometimes uropsychology. You need to be a bit of a psychologist and a reassurance and certainly if you not speak to the doctor, but the nurses to that doctor, they will have a different story sometimes to paint in those first few weeks. So it's important to really have that disclosure discussion, making sure that you prepare the patients and walk them through this journey. It's very rare, but there is reported, ejaculatory dysfunction. It's important that if you are wanting to do a resume and you want to protect, you really want to be staying a little bit further back to the verumontanum, the 3 and the 9 o'clock positions in aim anterior, understanding that some of the steam may propagate downward and may injure the duct or some of the ejaculatory ducts beyond the verumontanum. And infection, I guess the idea that you are creating some necrotic tissue. All the tissue doesn't mean it's going to slough. You'll have some areas that are going to remain tagged on. So those who've done your resumes before, I think will make smile when I say this, but there is sometimes some therapeutic cystoscopies during the first 3 months where you may want to look in and use the side of your cystoscope to sort of rub off small fragments of tissue that remain adherent to the wall of the prostatic urethra. Some of the data we'll dive through, and if you have not seen, I'll just share you. This is some of the work of Dr. McVary and the team that was part of that pivotal study looking at 5-year outcomes. And you can see there's your 3 month. That's where you see the big difference. But the first couple of weeks may be a little bit bumpy, what I call turbulence. But 3 months onward, you have a significant drop in the IPSS, and the Qmax up until we saw optimum BPH did deliver, a higher Qmax than some of the other devices that were more reflective, like UroLift with the IPSS, as much as it was the minimal for the Qmax. And across the board, quality of life, not much impact on erectile dysfunction. Because the heat only gets the outer, the inner capsule, doesn't go to the outer capsule of the prostate, which our neurovascular bundles are located. And I've had people actually getting off the 5 ARIs and having some improvement there, but depends on the age and the other comorbidities of your patient. So I don't make claims that it will improve, but it will certainly get them off meds. There's some other data that's been comparing the MTOPS data to Resume, showing the superiority of Resume. Moving ahead, just, ejaculatory dysfunction, very little reported on any damage or so forth, but it's not zero. I always tell patients it's around 3 to 5%. Technique-wise, try to make sure if you do have a young person, just like when you're doing an aquablation, you want to stay a little bit further away, and your energy that could steam come down, keep the steam up. 30 to 80, that's where we have our, indication. How about bigger than 80 grams? Add in COVID, where we didn't have much OR aspect, but we can do stuff in the office, enter some of the work we did here with Dr. Altman and myself, and, good number of patients, mean age of 69, volume here clearly, over 80 cc's, and I call them Canadian prostates, where we just give meds to the cows come home until your patients can't urinate. You see larger prostates, 2/3 have a middle lobe, and again, 21 had your retention. This large group that we had, mean number of injections was 13.6, but look at that, the OR procedure, we're talking scope in to catheter coming into the urethra under 6 minutes, and keeping the catheter longer. And if you look at the pivotal studies, they keep it in 3 days, but there's a 20% chance you're coming back. And we've just learned, hey, well, most people like that if you tell them you're going to take it out on that day and they don't take it out again, they're happy. But if you want to make them happy and tell them you're going to take it off after 3 days, there's that 1 in 4 chance they're going to come back and need a catheter. And I find those lead to a little disappointment, and no one likes that in terms of the journey. So again, keeping the catheter longer is what we found seems to be the right time, where you take it out, it stays out, and getting them through that inflammatory phase. And for those over 80 cc's, we'll look at that. They actually did as well in terms of, maybe not better, that drop in IPSS, which we thought maybe they weren't going to do because they were just too big. Well, not the case. And again, we were outside of needing a Resume Mega or a Resume 2, or they were looking at Excel trials that unfortunately didn't accrue. We never got that data. So the best we have, kind of like robotic radical prostatectomy, lacking of a randomized study, people continued using this, at least in Canada and other places, beyond 80. But there is some growing evidence, not just ours, but like Kevin McVary and a few others, looking at 2-3 year outcomes that it makes a difference. But again, it's part of now the portfolio, and having that shared discussion with your patient, individualizing your therapy to their needs, not just yours. And obviously the cost aspect as well. For men in retention, sometimes, we have that graph and we have the volumes, but then we got that other curve over here where patients are a bit frail. I did a patient the other week. He had a stroke, he had a heart attack, and he had a catheter dependence. And well, no one really he's not a candidate for anesthesia. So what other options we have? And now we can offer some patients this therapy. 16 men here, really larger prostates, not medically fit. And how do they do? And 1 month and at 3 months, that having that, just over 85% of men with catheter-free status. Sure, they're not going to have to hire just Q max, but for that gentleman who has a lot of comorbidities, just the fact that he's out with a catheter, we met the goal. And so again, the idea that we're able to keep these guys maybe with a catheter for a month, then remove it. You can see those success rates, on 15, not the hugest number, but there is evidence that it's going to work. And I just came across a paper. I was going to add it in for time's sake. I cut it out, but it was a randomized study, a match cohort looking at Resume versus TURP in men with retention. And obviously 1 month and 3 months, the TURP outdid the Resume, but matching up around 3 months onward. So it was in the World Journal of Urology from January. So again, if I kind of think about Resume, I remember Henry Wu at an AUA pulled me aside. He's like, Zoran, you got to, with this thick Australian accent, you got to hear about this Resume. It's like the surgical pill. You can do what you're doing with dual therapy, but in a 5-minute steam procedure, and you don't need to, go to the operating room. So I kind of recall and stuck in my brain, kind of like enucleation's enucleation, some, key things that stay and they'll be there forever. And it's great. I think that, the Resume is just one of our other tools that seem to be now with, our portfolio of things. It's a one-stop shop treatment. You can do this in the States, they do it because of coding, to bring someone to the OR and do a timeout and spend an hour for a 5-minute procedure. Probably not the best use of our resources, which are very crucial, but this should be considered an office-based procedure. It can be done, it just having the right equipment. It's a really low, retreatment rate at 5 years. Is it the 20-year durability? But, at this time in our age, kind of when you go to shopping on Amazon, not everyone, like I have other important things in my sexual functions. I want to get back to work. Again, these are just some of the options that we have to offer our patients. And now they're more than ever knowledgeable and they have their grocery list of things they want. But I think it's something that's easy to onboard. You don't need to do a whole fellowship. The learning curve is quite easy. And the reproducibility across anyone doing this, I think, is quite easy. As long as you have a finger to press a button, there's not like UroLift, you have to have different angles. Quite straightforward. You go in, pull back, you click the button, the needle goes in the same depth, no matter who is pressing that button. There's an automation process. Just marking yourself and making sure you do the same number of injections, you can get carried away. I guess that's the biggest learning curve. So again, 1 centimeter from the bladder, you don't want to be right there when you inject, so you diffuse into the trigone, stay back a bit. 1 centimeter apart, get the bulk of the adenoma, stay away at the apex for the ejaculatory ducts. The idea that does this happen to every person? This is kind of what I explain to patients, what you may look like at, 1, 3, 6 months, and you really get down nowhere beyond the capsule. Problem is you don't always get that. So you're going to be doing your treatments, and those in the room who'll do this, you'll press the button, you'll inject steam. It goes in like butter, there's even kind of a nice hum. And then even the same patients, another area, you may inject into the area and you get this huge escape of bubbles in front of you and you hear this vibration. Same patient. What's going on? And I think what we don't appreciate is if we do resections and we enucleate, well, maybe the enucleators, you get your beach balls. That's maybe what's happening. We don't know what's happening inside the transition zone. Prostate cancer patients, they have PIRADs, they have different algorithms on tissue composition. And I think, we need to get a better sense when we see our patients, not just a cystoscopy or our finger. Is there a difference in that chemical composition that even in the, if you look at this initial studies from the Resume, if you look along those graphics here, you'll see variable amounts of tissue damage they're going to be one person different than than even in the same injection. So you're not always going to get that 2 by 1 centimeter, like you see the red square insert. Well, you're going to get a lot more variability. And I think that's why, when you go in, you're always going to get various levels of reduction and tissue sloughing. And you may even get little pockets like this or diverticulum. These are more the rare birds that we don't always talk about, but we are just injecting steam, and how that person will slough or heal isn't always the same. And so, the whole idea that what we want to go in, and for those who've done a few of these, sometimes you'll go in and you won't get that same, wide opening defect that you would in these prototypical openings. So that variability, I think, relates to our lack of understanding of that differentiation of global versus stromal, which again, when you put in stents or you compress tissues, that may be why we're seeing these different levels of outcomes and retreatments. And had we had some kind of a gygometer measuring that density, well, if it's like hard cement, we're not going to put a clip through it. We're not going to inject steam equally through it. So I guess I think we're still a bit like the cavemen. The best we have is X, Y, Z, and multiply that by pi over 6. Moving with our technologies in yes or no middle lobe or anticoagulated. So, the idea of using ultrasound, measuring, and really having, be it periodical, seeing growth curves, and if we could, so maybe some elastography, measuring what's happening in the amount of tissue, taking into account, what we've learned with stents, the urethra is not a tube. It's actually a angled type of shape that is almost concave at some areas, and some cast models they've done from radical prostatectomies. And that angle, we've all appreciated when we do rigid cystoscopy, we've lost it with our flexible cystoscope. I always kind of think about Maverick and Top Gun when you're going in and you're doing your resume, and all of a sudden you're getting to the bulbous membranous urethra, and all of a sudden you got to change direction, and I'm talking like bang, like 10 G's. You're on the floor, you're looking up in a high neck, and I think there's something to be said about the urethral angle that we don't always appreciate. So in light of things, and I'll finish up with here, I think we've got some ways to go with perhaps better appreciating and characterizing the prostatic urethra, and how do we fit these kind of technologies or stents and whatever news coming our way to make sure we use the right ones on the right patients and save everyone time and money. So with that, I thank the team and take questions and go from here.
Thank you, Dr. Zorn, for an outstanding talk. For the sake of time, I think we do need to move on, so there will not be any questions. I'd like to present Dr. Shvero, who will talk about aquablation, a trend or a gimmick.
Good morning, everybody. So my name is Dr. Shvero from Sheba Medical Center. I'd like to congratulate the organizers of this wonderful conference. Okay, so I want to start with an apology, ladies and gentlemen. 2 inaccuracies in my presentation. One is the name that you have in your flyer, a trend or a gimmick. I think that everybody knows that aquablation is far from being a gimmick. Maybe 5 years ago it was true, maybe we were skeptical. Now with all the data we have, with all the experience, definitely not a gimmick. Second is the location of the presentation, because before me is the resume, after me is the PAE. It's not a minimally invasive. I mean, it's not a mist. It's an ablative procedure. You leave the prostatic fossa empty, wide open. It needs to be compared with whole lip, with open prostatectomy, robotic prostatectomy. All right. Carry on. So aquablation, or as I like to call it, robotic-assisted aquablation of the prostate. First and only image-guided, robotic-assisted, heat-free water jet treatment for BPH. It involves personalized treatment planning, right, with designated software. See here in the image, a very fertile ground for AI. That's the next generation of the machine. Practically for all prostate sizes and shapes, maybe except the very, very large ones. A month ago, I did a 285 grams prostate with this machine, 80-something minutes, open wide niche. Everybody's happy. after the machine is working, as you see second illustration, you go inside with a resectoscope, do that in all cases, and cauterize around the bladder neck. And if I'm inside with a resectoscope and I see a reason to resect some of the tissue, mainly on the interior part, then I can. There's nothing wrong with that. And I do that sometimes. Say 5 grams, 10 grams, if it's needed. Right? So, and the main thing about aquablation, didn't see other procedures of a mist, yes, but not ablative procedures, is the preservation of sexual function. Most of the patients, as you will see, preserve their antegrade ejaculation. That's a revolution, because it also provides the symptoms relief of an actual procedure and preserve antegrade ejaculation. So everybody's happy. All right, so it's a small illustration on how it works, because not everybody knows. That's a video by the company. Okay. Forward to save on time. No, not. All right. So it starts by inserting a truss ultrasound probe inside the rectum. You need to get a good image of the prostate and the pelvis. You see the bladder neck. You see the virmontanum. You see the entire prostate, peripheral zone, transitional zone, the urethra, 2 planes, axial, sagittal plane, and then we insert the handpiece of the machine, the robotic system. You see here, inserted inside the urethra. Starts by firing at the tip. It's second. It's fixated to the table. That's that cryotherapy and all that. Then you work with the interface. Gloves on. I work with a keyboard and a mouse. And I plan on the axial view. I plan the area of dissection, of resection. See the peripheral zone at the bottom, the entire transitional zone, entire adenoma. Move to the sagittal view. Right, see the bladder neck where the pointer is pointing, and the bladder on the left. We have methods of maintaining and preserving both the bladder neck, the sphincter, and the virmontanum. So we plan every dot and every color here matters, of course, all the small subtleties of the procedure. Then, after we do that, complete planning, we let the machine work. Between, say, 5, 8, 10 minutes. That's the entire ablation. This is the illustration, of course, but it looks very similar to that. See so that's times 3 speed, not times 30 speed. Very quick, the procedure. Usually I do 2 passes. Studies show that it's better. So that's the cystoscopic image. The arm, the body comp does like that. And at the same time, sucks out all the fluid with the grains of tissue. There's no pathology from this tissue. So when this is over, I go in with a resectoscope and cauterize the bladder neck. This is how the OR looks. I have a keyboard and a mouse. All right. So currently, not exactly currently, but through the last March, about 40,000 procedures, even 50,000 procedures were performed globally. A couple of hundreds, about 300 or 400, 100 machines worldwide. So the data that is available, that's from the company, right? Average prostate was 89, and the median was 80 cc's. See that most of the procedures are on prostates less than 100. So it's actually, aquablation competes with other, with all other procedures, right? Both HOLEP, both TURP. Okay, so the first trial that was done was a randomized prospective trial of aquablation versus TURP. It takes a lot of guts to do the first trial you do and go against the TURP, which was back then the gold standard, and still probably. So 181 patients. First paper was published on 6 months follow-up. The last one had 5 years of follow-up. Prostates were up to 80 cc's, because it had to be compared to TURP. Similar operative time, similar efficacy in urination parameters. Cis, etc. You'll see only 10, and the big surprise was only 10% retrograde ejaculation with Aquablation. That's a revolution. And in 5 years, 51% less recurrent BPH treatment for Aquablation. Only 6% of patients needed some sort of BPH treatment, medicine or surgery, compared to 12% of TURP. So the second trial that the company did was the Water 2 trial. It was a prospective single-arm trial for prostates sized 80 to 150, right? 83% had a median lobe. Operative time was 55 minutes, which is rather quick. IPSS improved by 15.9, which is a lot. Qmax by 9.2. Only 3.7% recurrent BPH surgery for 5 years. That's very low, better than TURP, comparable to HOLEP, and 85% antegrade ejaculation. Okay, so both these trials led to the approval of the procedure FDA-wise, and we compare both trials. One had prostates between 30 and 80, 80 and 150. You see that the efficacy is similar, so it was approved, and we could continue further. The open water study, another study that was published by the company, not by the company, but with the support of the company, prospective single-arm, multi-center, open-label study, all comers, right? 20 to 150 cc's. Back then, I mentioned here, they didn't do the focal bladder neck cautery after the procedure. They just did the ablation with the machine, and then put a catheter in, filled the balloon with a lot of fluid, did traction. Back then, the transfusion rate was around 3%, and 8% of patients went back to the OR for a TUA. You don't see these numbers anymore. You see. So back then, the procedure was notorious for being, more bloody. Right? But as time passed, we could develop new methods, and now we just the genius idea of going in and just cauterizing where it bleeds. Okay, so there was another open trial, the France trial, but altogether 425 patients, all clinical trials, IPSS improvement by 16 points, comparable to HOLEP. Peak flow at 20.5 cc a second, which is great. Ejaculatory dysfunction 10.8% only, marvelous. Incontinence 0.5%. That's what I see in my practice also. So there's no problem of incontinence, and I do HOLEPs as well. HOLEP is a great procedure, wonderful procedure. It opens up the niche greatly, but if the patients are not happy, especially in the months after the procedure, when they sometimes leak, then you wonder if you should have done something else. This procedure, like TURP, you don't see much of that problem. What about operation time? So Aquablation is on the blue here. This word. The pointer. This is the pointer. How to operate it. So this graph here represents the Aquablation. See that as the prostate enlarges, right, the operative time doesn't rise much. And you see that in practice. A HOLEP here takes time to do large HOLEP. And that's fine, that's okay. I mean, patients probably don't mind if they're operating on for an hour or 70 minutes, right? Or 80 minutes. They don't mind. But still, it's a resource that we need to take under consideration. Okay, well, what about bleeding? Happens now. So in a trial that was published by Dean, so 2,000 cases they did, and they did that focal bladder neck cauterization. They saw only 0.8% transfusion rate and 0.6% TUF. That's great. That's marvelous. That's what we see. So this is a small video, how it looks after you do the aquablation. So when the machine works, it ablates all the tissue. When you go in with the vectoscope, basically there's a very large niche, irregular, bleeding. It's a hard territory. So the most challenging part of the procedure is not the ablation with the machine, right? Because that's very sterile, anything works. It's the IUA for the cauterization afterwards. So there's definitely a learning curve in that. So this is something that we're not used to. We control, when we do a TURP, say, we control the anatomy, we know where everything lies. Here, sometimes at first I don't. But as time passes, as experience gained, it was fine. So that tissue here, that fluffy tissue here, is the remnant of the median lobe that this patient had. And that's what the machine does. It turns into fluff and then it gets it away. Sometimes the remnants of that. That's the bladder next. It's completely open. No need to resect much. Only cauterize a little bit. You see that I do that. It's like everything is wide open, of course. And I use actually monopolar. That's what I'm used to, but you can do it bipolar, whatever you want. So bladder neck is preserved completely. You see it properly in the ultrasound. You don't harm it. You don't need to resect it here as well. After you see what's going on, just that's a little bit. Resect a little bit if we want, but it's the bladder neck is right there. So this is a nice example of the bladder neck, but sometimes it's a little bit more challenging than that, right? So when I went into that 285 grams prostate, there was a gigantic fossa, and everything was irregular and bloody. And this part took me 45 minutes, I think, something like that. If there's a little bit of tissue, you can take it. It's fine, nothing wrong with that. But the purpose of the this part is to cauterize the bladder neck. All right. See the plane, it's a very nice plane. No adenoma tissue here. This is the case I did a couple of weeks ago. But it's not an example case. It's not a very small prostate. It's just a regular case. All right, so our cohort, we did 181 patients, prostate size, median prostate size 95 cc's. That's respectable, I think. The smallest one I did was 27. That's actually pretty challenging, the smallest ones, because you don't see the planes as well in the ultrasound. Big ones, you see the plane very clearly. You see the TZ, you see the peripheral zone, everything's very clear. The small ones, you're not sure exactly where the bladder neck is and where the velometanom is in the ultrasound. And you got to be more careful. So procedural time 15 minutes. Length of stay between 1 and 2 days. I take the catheter, of course, before they go home. Hemoglobin change only 0.9, which is marvelous as well. 3.3% need for blood transfusions, and I took one patient back to the OR after a week. He wasn't that bloody, but he didn't manage by himself. So, IPSS dropped by 12.9, quality of life by 2.3, and actual get ejaculation, 86% of patients. I did see a learning curve in that. I think it started at around 70% actual get ejaculation, went up to 80. The last, say, 80, 100 cases were between 85 and 86%. Great. That's it. No question for that.
Thank you very much.
Question?
Thank you very much. Time is of the essence, but I have two small prerogative questions. Are you ready? Ready. Perfect. So maybe I would like to also address this question to Dean Elterman and Kevin Zorn. So guys, are you with us? Kevin, Dean. So first question, I would like you to comment on the publication by Professor Andreas Gross from Hamburg. So I respect Professor Andreas Gross, is one of the leading endourologists in the world. So the data on his data on aquablation to rectal perforation with about, if I'm not mistaken, about 100 cases to rectal perforation, a lot. So I asked this the same question to Professor Gross when we met face to face. So he said that aquablation is not his favorite procedure. The answer was like that. But could you please comment on that? So what you think was the reason for such serious complication and how we can prevent it in future? Thank you, guys. We're looking forward to hearing from you.
So
Dean?
Dmitry, I can answer that question because I actually reviewed it for the FDA. And in fact, the rectal perforations that have occurred around the world have uniformly been from the transrectal ultrasound probe, and it's been at the time of the insertion of the probe. And there is no incidence of the water jet, the aquablation itself, or the scope causing rectal perforation. So the key message really is the very careful and gentle insertion. And a lot of these men, actually, half of them had unrecognized rectal pathology. So they had either a colon tumor, previous colorectal surgery with scar tissue, so something. So the bottom line is you have to be very careful, be mindful when you're putting in the rectal probe. It's not just put it in and go. It's a key component of the case that needs to be done carefully.
And if I could
Thank
add,
you, Dean. So, yes, Kevin. Kevin, please.
I understand that, but there's also, again, this down uniformity of the procedure. As we know, aquablation is the device, the treatment. Then there's the bipolar. There's other things that are not controlled by the company, and the anesthesia. So in that study, there's some patients who didn't have a full general anesthesia, and everyone in the room will laugh because everyone who does a spinal, what have we all say they did a good spinal, but not everyone has a spinal gets a good spinal. And if someone's moving around, they're sedated, and the patient wakes up and they're moving, there's also been some elements of that. That's potential for rectal injury, not necessarily at the insertion, but potentially during the end or beginning of the case where they're sedated and they wake up a bit and they're moving and you have a fixed object, inside the rectum. So I think those are other elements that have to be factored in. But I completely agree with Dean. There's never been a water jet itself. And Dr. Helfen has been doing some work with the aquablation, firing deeper and doing third passes toward the outer capsule, and deliberately in cadaver studies trying to go beyond, and again, very difficult to do so. And I think that's just an adding safety that the jet itself is not the issue. The culprit is the patient moving or pathologies. And again, the idea that you have a fixed, the ultrasound probe is the danger.
So guys, am I understand you correctly that the problem was that the ultrasound probe was too close to the rectum? That was the reason? So during navigation,
it has to
could you
do
please
with
clarify it?
It has to do with the angle that you go in, and whether there's a rectal fold that gets in the way. So you have to remember that once you put in the aquablation, you angle upwards to compress the prostate. But when you insert the probe, it needs to be put in flat, parallel to the floor, flat. In fact, you almost want to angle down. Think of like how the colon travels. You're going to go down, in, and then gently compress up. You don't want to be going in like an airplane taking off.
It's now it's absolutely clear, Dean. So it's a very important advice and very important note for you. Yes, Thomas, please.
It just shows that it's always the driver, not the car. So you can buy an aqua ablation machine, which fortunately does no longer run under aqua beam, because beam we know from Star Trek, beam me up, Scotty. So that is not a beam of the transitional zone, but an ablation. So it's a learning curve thing. I think it's, of course, this is a super experienced center which had previous vast experience with HIFU, which basically used the same probe basically to monitor the progress and do the ablation. But in the end, we have to consider this is, of course, setting, training, and I think this is why I was at that time as the person who was guiding this paper very much in favor to publish this, to create some awareness for that, not to blame this machine, which is and it opens a gate into the future of image-guided surgery, but to address it, to build it in training, and to avoid it in the future, because that is the best thing to do. We have a fundamental underreporting bias of complications, and this probably singular publication created awareness, and I think this is no longer an issue whatsoever because it has extensively now been discussed, and that's it. And this is why it is sometimes valuable to publish things like that.
Thank you very much, Thomas. Thank you very much. We are moving forward. Thank you, Asaf. Thank you very much once again. So we are moving forward to Dean Elterman, to Eurolift. Once again, I would like to thank Dean and Kevin. I know that it's late night in Canada now. Guys, thank you for finding time and join us. It's really real pleasure and to see you, and thank you for joining us. So Dean, please, the floor is yours. We are all ears, please.
Thank you very much. You can hear me and see me okay? Just give me a thumbs up, Dmitry.
Yes, we can hear you and we can see the presentation.
Right.
Perfect.
Wonderful. Thank you. Nice to join you. Boker Tov Kulam. It's my pleasure to see you and present the Eurolift, when, how, and for whom. I'm a urologist in Toronto, and I'm really proud to now be one of the associate members of this section of endourology and also functional urology, the EAU. And I think this type of program is really an example of how we can collaborate. So prostatic urethral lift, I think this has been around now for a while. We're quite familiar with it, but I'm going to take us through some of the key aspects, some of the studies, and maybe a little bit of the technical aspects as well. So we know that the prostatic urethral lift, the mechanism of action is to mechanically open up the prostatic urethra. And very importantly, it's creating an anterior channel. And this is key. You know, we are not trying to open up the entire transition zone. We're not trying to open up from the top of the prostate all the way down to the bottom. It really is an anterior channel. And the results are directly visible during the cystoscopy. And importantly, the implants are placed anterolaterally. And this is what A, creates that anterior channel, but B, avoids the neurovascular bundle and the dorsal venous complex both above and infralaterally. So the placement is actually very important. It is a cystoscopically placed procedure, and it is really being done to compress these encroaching, obstructing lateral lobes. On average, in a 40 to 50 gram prostate, you're going to be seeing about 4 implants placed. Now, when we think about patient selection, certainly in the EAU guidelines, it is for moderate BPH under 70 milliliters. It is for lateral lobe obstruction. The guidelines still talk about an absence of a median lobe, and importantly, it's for men who want to preserve ejaculatory function. From the manufacturer, it is actually fine to use for median lobes. There have been a number of studies that I'll review. In the United States, the label has actually been upgraded that it can go up to 100 milliliters or 100 grams in volume, but otherwise it's the same as the EAU. You know, from my perspective, I think you want to avoid those patients who have a high bladder neck. The median lobe is, I think, a little bit challenging, but certainly possible. It is for prostates between 30 to 80. It can be done in patients with prostate cancer, of course, but I prefer to choose other modalities for men who are on active surveillance just because of the issue around MRI artifact. It can be done in some post-radiation cases. And again, I would prefer this, say, over a resume case that I would never perform in a radiation case. And some medically complex patients, I think, are perfectly fine for this. So when you think about how to image and work up these patients, you really want to think about assessing the intravesical prostatic protrusion. You want to assess the height and width of the prostate. There was going to be a picture here of both cystoscopic view and ultrasound view, and I think those are both key components to include. Now, the delivery system itself, this is the model that's available around the world. There's a new 2.0 model in the US that I'll show you. But essentially, it's just 4 steps. The first step is number 1, which is the release of the safety lock. I do this as soon as I put the device into the bladder. Number 2 is the blue button, and that is the needle trigger, which is fired. It deploys the needle and the capsular tab all the way out to the capsule of the prostate. Number 3 is when you compress, you pull back this lever, and this is what delivers the capsular tab, and it's going to tension the suture. And then finally, when you come back into the midline, and I'll show a quick video of this, you're going to release the urethral side of the suture and cut any excess amount that's left over. So I think this is a really good way to visualize where you are placing the implant, and the technique is really key. If you divide the prostate into thirds, a top third, a middle third, and a bottom third, we're really trying to address the top third. And when you're angling, you're going to almost angle in from where the sphincter is, and you're going to create this anterior channel lengthwise from the bladder neck back to the verumontanum. And it's really important to hold the hand piece parallel to the floor. I used to kind of hold it like a gun sideways, and now the direction is kind of just to like hold it in your hands nice and flat and move it. And now the tip of the device is going to be in that anterior third of the prostate. The angle with which we deliver and compress the tissue is actually really important, because the way that we compress the tissue will actually impact how the capsular tab comes out and the trajectory of the needle. So you can see here that if you are just really almost flat on the midline and you don't angle in, the needle is going to go out 12 millimeters in front of you. And you can imagine that if you're close to the bladder neck, you actually may get a suture and a tab going right out into the bladder. And as you see, with every incremental angulation inwards, 10 degrees, 20 degrees, 40 degrees, you're going to see where the needle goes. So optimally, you kind of want to be around 20 degrees from the midline. And then you know that your suture is going to go kind of where you are compressing. And that's really important. Now, if you do an obstructing median lobe, OML, it's important to get at least 20 or more degrees of angulation so that your needle goes right through the prostate, out to the capsule, and doesn't go out into the bladder. So here you can see the angle of compression, and it's that 20 degrees, and you can see that if you look at that incorrect picture, you see how the needle is going to go in front of where you are. Whereas if you compress those 20 degrees and you angle in at the fulcrum of where the sphincter is, you're going to get right through the capsule to penetrate with your capsular tab, and you're going to avoid the bladder wall. So it's a key component. It's really this angulation. When we do resume, I angle in about 10, 15 degrees, but that's really just to bury the needle. I'm not compressing the tissue. Here you're angling and compressing, which is really key. The other maneuver, which is important, is that you have this little keyhole, this area within the metal, a window, and you can see the blue suture. And there's going to be a little white line that begins to appear as you take away that angle and move forward into the lumen. And once you begin to see that little white line, that's when you know that you can release the suture, and it will cut the suture and deploy the urethral luminal tab. Let's see. And this is a nice picture here. You can see inside where my cursor is, that little white line is very not distinct. You have to really look for it, but that is the key part of looking for this. I'm going to show us a really quick video here. Going ahead here, we're doing a pre-cystoscopy, looking at the lateral lobes, and you want to assess the length of the prostate. And then you're going to place these. So here, so what we're doing is we're compressing. We're in the anterior 1/3 of the prostate. The handpiece is now angled parallel to the floor. See, we're not really angling up or down, it's flat. And the suture is now placed through the capsule. And then there's a little bit of a forward motion. We saw that little flash of the white line, and then the suture is cut. And then we're going to do the exact same thing. You're going to come back. Here, there's a little bit more tissue. So here we're coming more distal. You can see in the background the first suture. This one's being placed a little bit more lower. And then again, move forward until you see that little white line and release. And you're starting to see this anterior channel open. I almost think of like a Foley catheter that passes through the prostate, right? It is creating a lumina channel, but not the whole prostate. Here, there's a shot. We're going to move back to the midline, move a little bit forward. You're going to see that white line, and then you're going to compress. And then at the very end, that's that final little suture that you can cut. And here you can see now an opening. It doesn't look like the cavity you have with a TURP. It doesn't look like the cavity you have with an aquablation or HOLEP. It is subtle, but it does improve symptoms, no doubt. And we see that in the clinical trials. This was the pivotal LIFT study, 19 international sites, prospective randomized against the sham. and you see a really significant, about 11-point reduction in IPSS within about 2 weeks. And then it's been fairly well sustained out. It is a 5-year study. Now, the retreatment rates are notable, and I think if you dig into the data, you can see a couple things. So number one, the percentage of men who go back on medication is 11%. That's the same that was in the RESUME-2 study. The amount of men who need another BPH procedure is around 14%. Now, there's about 13% of patients that were lost to follow-up, but this is true of all studies. But the last part is that there's a surgical reintervention rate for complications, which means issues with the implant itself, whether they had to be removed, for example. So if you add this all up, it is almost a third of patients may need another type of procedure done. But when you look at all the different studies, it is certainly reproducible. So whether it was the pivotal study, whether it was the study against TERP or other studies, you really see the very same improvement in IPSS, pretty rapid and durable. What about patients in retention? I think this is a really interesting cohort to look at. There have been 2 very large studies. One was a real world study of thousands of patients, and one was a controlled study called the PULSAR study. And we see an improvement in IPSS, again, very similarly, including in the retention patients in that dotted line. And how effective is UroLift for retention? Well, in the real world study, it was about 84% of men who were catheter free. And in the controlled PULSAR study for urinary retention, it was around 73%. So you can say 73 to 83% catheter-free rates. So that's something that you can look at for patients. Now, one of the benefits of all minimally invasive treatments, and it's certainly true for UroLift, which was the first to come out on the market, is the ability to do it under local anesthesia. So you can really treat a broad range of prostates, including a median lobe and urinary retention. You can improve hospital efficiency if you do this under local anesthesia, because again, it's pretty straightforward. You can improve the back-to-back, how many cases you can perform. You, of course, save hospital beds, which is important in some countries, and these patients can go home typically without a catheter. In the LIFT study, about 1/3 of patients went home with a catheter. So this brings us to the median lobe. This is a technique that has evolved over time. It is done. It is a more challenging technique for sure. And it really involves the idea, I'm going to take you through this. You want to check the mobility. You want to push the median lobe to the one side, to the other. You want to see if there's a groove or a cleft that's easier to pull in and downward. And essentially the idea is to depress downward, laterally, and almost into the prostatic urethra to pin it down out of the way. And it's really important that you pin it down and stay far enough back from the bladder so that you don't get an implant there. So you first want to treat the lateral lobes. Then you want to assess from the distance from the verumontanum to the bladder to see how obstructing the median lobe looks. You want to compress the tissue. Some people actually compress it so much to push almost all the blood and fluid out of it to get it really sort of soft. You don't want to force it. And then you're going to compress. You want to maintain that compression. You have to now rotate your device downward, because as opposed to being up in that anterior third, going outwardly at that 20-degree angle, here you almost have to take an acute angle downwards, aiming down towards 3-4 o'clock on the prostate, and then pass your suture through it. And you can see here the schematic. They did a study called the MedLift study, and they were able to show whether you have a median lobe and you do this technique, it is the same outcome as a normal UroLift procedure done. So here I'm going to show you the compressive median lobe. So they're going to just take a look at the median lobe here. You see he's assessing left side, right side. See, there it is. You can see that it's really filling up the bladder outlet. He's looking on the right and left. And then he goes in with the device, and he's going to start to try and manipulate it. This is not a quick maneuver. You have to spend a little bit of time finessing, assessing, moving the middle lobe around. You see he's going to try to sort of get on the patient's right and push it down. And he's going to see whether that works on this side. You can also try on the other side. And he's really trying to almost compress it within the prostatic urethra. There's no point to push it out into the bladder. you don't want to pin it down in the bladder because you don't want any of the implants to be exposed to urine and have incrustation and stone formation. So you see it's a little bit tricky, compressing, pushing down, and almost pulling in to the prostate. Then he's going to shoot it like a harpoon. The UroLift implant's going to go through in a down towards the 4 o'clock position eventually. So you see he's compressing, compressing. It takes time. This is really one of the slower maneuvers. When you do the lateral lobes, you can go in, boom, put in your implant. But here, see now he's going to release the tab, and you're going to see that it's pushed over to the side. He's going forward a little bit to release the tab. You want to see that white line? There it is, and then it's the release. So you can see now the lumen is much more open. That median lobe is being pushed to the side. It's not going to look the same as a TURP, as I said, but it is going to be much more open and out of the way. This is my local anesthesia protocol. So if you can perform this, or if you choose to, you can give some pre-medication with oral medication. You can give a lorazepam, you can give pain medication, you give an antibiotic, and then you can fill the bladder with chilled lidocaine. And then you can put in lidocaine gel, also chilled, into the urethra and clamp the penis for 20 minutes. So this combination can be performed and safely in an office setting. There's now a couple new UroLift implant devices. They have now this wings called the Advanced Tissue Control, or ATC. And you can imagine that these little wings that come out from the end allow to sort of hold and manipulate the tissue a little bit easier. And the UroLift 2 system, which I believe is only in the United States, allows you to almost change the cartridge of each implant one at a time, as opposed to each handpiece being used only once. So there's a lot of waste of material and waste of time, in fact. So you can see how the ACT kind of compresses, captures the tissue, these wings, and pulls it out of the way. And I'll show you very briefly in this video, if you can see, this actually has the ACT, and it's really just pushing the lobes to the side. It just has a little bit more material to get control of the tissue and move it out of the way. And so here you can move around and really manipulate the tissue. There's the wings on the left-hand side of the screen, and it's a little bit easier to stack and place these implants. So the bottom line for me, I presented this to AUA last year. I think UroLift is good for prostates between 30 to 100 grams. That's the labeling. Certainly it's much better for 30 to 60, 30 to 70, you can argue. It's very good for lateral lobe obstruction. It's excellent to preserve ejaculation. There really isn't any loss of ejaculation with UroLift. So if that's a key priority for a patient, it has essentially an absence or minimal catheter time. And they do have studies indicating that it has the fastest return to work, fastest return to normal activity of all the minimally invasive treatments. So that could be a consideration. Who to avoid it in? High bladder necks, very large median lobes, and again, those men on active surveillance. But like anything, success is about proper patient selection. One size does not fit all. You need to really choose those patients who have lateral lobe occlusion and not a bladder neck component, because you cannot put the UroLift across the bladder neck. You have to use it some caution with these median lobes. As I showed you, it is a tricky but doable technique, but it has very good results for sexual function and ejaculation. The outcomes, we have these 3 to 5 year outcomes. Durability is okay, but again, as I showed you, the retreatment rate with medication, surgical intervention is notable and should be discussed with patients. You can certainly redo it in the future or do another minimally invasive treatment or TURP in the end. And the new devices coming out has certainly improved both visualization and less carbon footprint and waste. So with that, Toda Rabah, everyone. Thank you very much, and warm greetings from a very dark early morning in Toronto.
Yes, Dean, thank you very much. So, breaking stereotypes. So, for a long time, I was sure that median lobe is a contraindication. Now we see that it's absolutely not a contraindication for UroLift. Another question, short question. So, acute urinary retention. So, please correct me if I'm making a mistake. So, patients with acute urinary retention was a contraindication for UroLift. Am I right or not? So, and is it really so now?
Acute retention was a contraindication, and then they did the Pulsar study, which was designed to treat men in retention, and then they did this real world, study that corroborated that. So You can do it in retention, and the success rates are 73 to 83% catheter-free rate.
Thank you. Dean, once again, thank you very much. We are really looking forward to seeing you soon in Israel, and you're always welcome. So thank you very much once again for being with us and for this amazing talk. So guys, we're moving forward. Now we move to prostate embolization. So very specific topic because not urologists perform this type of treatment. That's why I think it will be very interesting to discuss it with Dominic from Switzerland afterwards. So please, we are looking forward to this presentation.
Hello, everybody. It's a pleasure. Hello, everybody. Thank you very much for the invitation. It's really a pleasure to participate. I've recorded the talk, but will of course be available for questions afterwards. These are my conflicts of interest. Most importantly, I'm a urologist. According to the title which was given to me, I will briefly explain how PAE works and what you can expect in terms of outcomes and safety. We will talk about tips and tricks from a urological perspective, which is mainly patient selection, of course. And then I will share my thoughts on the challenges and perspectives of PAE. So this is a brief history of PAE. And as you can see, it's been around for quite a while now. Implemented for refractory bleeding in the late 70s, a reduction of Lutz BPO was described in 2000 for the first time. During the following years, there was a growing body of evidence, and nowadays we have a number of RCTs against TURP, sham treatment, and pharmacotherapy. This increasing evidence has led to successive inclusion in urological guidelines, starting with NICE in 2018, EAU in 2021, and most recently in the German and American guidelines. Although, as for many other myths, there are still restrictions. For those who are not familiar with the procedure, let's take a short look on how it works. To puncture the femoral artery, you require only local anesthesia. Using angiography, you can identify the prostate's blood supply, and a microcatheter is advanced very close to the prostate. If you are not sure, you can do a cone beam CT, and the prostatic arteries are then closed using microparticles, aiming at a complete absence of the normal blush of the prostate. So this is the picture after embolization. It's a really elegant procedure. But what outcomes can we expect after PAE? Well, assessing a number of RCTs, the Cochrane group concluded that PAE might lead to the same reduction in IPSS as TURP in the short to midterm. According to our personal experience and meta-analysis, TURP was also only slightly superior. However, regarding functional outcomes, PAE is clearly inferior compared to TURP. As an example, the change in maximum urinary stream is illustrated here. Why is that the reason? Most probably because, according to urodynamic studies, only 1/3 of the patients have clearly no obstruction 12 weeks after PAE, while 1/3 remains equivocal or obstructive, respectively. What else can we expect from PAE? Well, prostate volume will decrease by an average of 30%. On the other hand, pretreatment rates are really depending on patient selection. So in more or less unselected patients, you will find considerable pretreatment rates between 10 and 20% after 2 years. In our trial, it was even 40% after 5 years, but those were patients with an average post-void residual of around 200 cc and rather 2 small glands. So retreatment rates were clearly lower in other studies. What about safety? Well, for sure, also PAE has a learning curve, but in general, it's a really safe procedure. In meta-analysis, we found that approximately 50% less adverse events occur after PAE compared to TURP. The Cochrane group agreed with this, despite being not completely convinced by the certainty of evidence. According to the literature, the top 5 complications are really mild, including UTI, pain, and irritated voiding symptoms. In contrast, severe adverse events are really rare. So I think the most considerable pros for PAE are that you can perform it with really any ongoing anticoagulation, and there is no upper size limit for the prostate. In addition, it requires local anesthesia only. On the other hand, availability and severe relief of obstruction are the main drawbacks. In addition, it's not suitable for small glands and requires radiation exposure. So what tips and tricks can I provide? Nowadays, it is common knowledge that the bigger the prostate, the better PAE will work. So the optimum threshold to predict success and failure in our trial was 40 cc. But this was a trial with small and medium prostate volumes, and personally, I do not recommend PAE if the prostate is smaller than 60 to 80 cc nowadays. I rather go for resuming for the smaller glands. And as for all myths, you have to ask the patient for his priorities. So I really agree with the EAU statement that PAE should only be offered to patients who wish to have a minimal invasive treatment and accept less functional outcomes. But this is the same story for other myths, of course. This is a common question. Is PAE a good option for frail patients relying on a catheter, considering its suboptimal relief of obstruction? There are 2 observational studies addressing this question. Both are rather small, but selected the patients wisely, so very large glands in these studies. And success rates were around 87% and therefore promising, which matches with my personal clinical experience. What about vascular disorders? For sure, PAE is more demanding in such cases, which is reflected by higher procedure and fluoroscopy times. But there is no significant impact on treatment success, which has been shown in a variety of studies now. What are the challenges with PAE? Here are the 2 most important ones in my opinion. We really have to stay the gatekeepers. There are multiple other reasons for LUTS and multiple other options for patient-tailored treatment. So establishing the indication is a core competence of urologists. And by cooperating with our IR colleagues, we should avoid that patients are directly referred to the IR without proper urological workup, as described in this study by Sharma. On the other hand, if you want to refer a patient for a PAE, look for centers with highly trained IRs with specialized facilities, because this is a difficult intervention which does not come without a learning curve. Does PAE have a future? Is it here to stay? I'm afraid that the reality of BPH treatment in 2024 looks like this. We have a variety of treatment options and everyone wants to get a piece of the cake as large as possible. And I can understand that IRs often might feel like this guy here because they normally do not have primary access to the patients. So normal urologists are still the gatekeepers, and in general, there are limitations of myths like PAE. So widespread use seems very unrealistic. However, while urologists switch their toys every 2 years or so, IRs will adhere to the technique and probably refine it. So a long-term use limited to special scenarios is very likely, in my opinion. Finally, what about PAE in the treatment of prostate cancer? This is a systematic review that we did very recently, and PAE seems to be safe and feasible in different scenarios like treatment of localized prostate cancer with a curative approach, advanced prostate cancer palliative, prostate cancer with hematuria, chemoembolization, or radioembolization. And it's effective in treating LUTS BPO in these patients. However, the oncological benefits are very unreliable, most probably due to a lack of control of heat distribution. So you don't know where your embolization beads will finally end up, through in the prostate, but rather in the central gland in the peripheral zone. But still, it's an interesting approach, and I'm excited for upcoming research. Summarize the available evidence shows safety and efficacy of PAE, but also its limitations. PAE is a guideline recommended procedure now that requires appropriate patient selection, like all BPH procedures, of course. In my experience, PAE facilitates a more patient-tailored treatment and provides an elegant solution for some very challenging cases. So I'm happy to have another option in my toolbox, despite PAE being not the one you will need most frequently. Thank you very much for your attention, and I'm looking forward to the discussion and to meet you in person in the future.
Thank you very much. Thank you, Dominic. So, very brief question. So, not urologists do this procedure, interventional radiologists. Could you please clarify the same situation in Switzerland? So, interventional radiologists mostly do this procedure. What is the role of urologists?
Yeah, it's absolutely true. These are only interventional radiologists, also in Switzerland. And if you go and watch a procedure, you will absolutely understand that it makes no sense for urologists to get started with this, because it's really, really demanding. And the IRs, they have so much experience. Many of them have like 10,000 procedures. And absolutely, as a urologist, it's not a good idea to try this. So it's the same in Switzerland. And the thing is, what is our task? It is to select the patients. Because like I showed, there are so many other reasons for LUTS. Not everyone requires an intervention at all. And on the other hand, it's about a patient-tailored treatment. And as I said, I think the minority of patients are really suitable for PAE.
Thank you. So very brief last question. So these patients with LUTS, they don't go to interventional radiologists, they go to urologists. Could you please, once again, summing up, highlight which patient exactly would you send to embolization?
A patient that is in general suitable for a minimal invasive therapy. So if you require maximum relief of obstruction, then it's not embolization, then it's rather enucleation. So the bigger the prostate, the better the outcome of PAE will be. So if the patient is, for example, frail, has a large prostate, has hematuria, for example, then it's an appropriate candidate. Yeah.
Okay. Dominic, thank you very much. Very interesting presentation. Frankly, the data regarding using embolization for prostate cancer, I didn't know about it. So it's really very interesting. Once again, thank you for joining us. Thank you for finding time. And we are also looking forward to seeing you soon. Thank you very much.
Thank you for having me. Thank you so much.
Dear colleagues, we move to the last presentation of this session. And my good friend, Dr. Javier Romero Otero from Madrid, the head of Rock Clinic in Madrid, so is here. So it's very interesting because Javier is also experienced in enucleation and in robotic surgery. And today I asked Javier to give a presentation on robotic simple prostatectomy. We know that this procedure is very popular in the United States and also now in Europe. But what is the role in enucleation? We have very hot discussion in our next section. But now let's focus on robotic simple prostatectomy. Javier, the floor is yours, please.
Thank you very much. I would like to thank you for your kind invitation. Hopefully, in the next future, I can be in person in Israel, that I will love it. So congratulations for the meeting and thank you for including me. As we are speaking the whole morning, if we look at our guidelines, the European guidelines, that they are my guidelines, if you look at them, we cannot find a role right now for robotic simple prostatectomy. but it is being a procedure that it is there. So if we look at this algorithm, we cannot find it. So that means that we have not enough evidence still to include them in this algorithm, and we have to work on it. If we look at the classification in our guidelines, we can see that in enucleation we have a lot of procedures. So that means that enucleation is like the tendency of all of us, because at the end of the day, we are achieving the best functional results with enucleation, and probably the majority of urologists, we are working on that. I would like to clarify something. I began doing enucleation in 2007. I have done more than 4,000 enucleations in my life. I have published many papers about this. And I am working not only with holmium, but also with thulium, and not only thulium, but also TFL and the new thulium laser. So I am an enucleation guy. But why did I begin doing this robotic simple prostatectomy? This is unpublished data. We are cleaning this data, but what I would like to share with you is that when we are working with prostates smaller than 100 milliliters, the surgery time, it's like a linear line, 60 minutes for this kind of procedure. Well, it's and 81 for bigger than 100. And what I would like to show you is that the enucleation time, it is not very different. It is only 10 minutes, the difference between these two groups. But if you look at the morcellation time, it is like increasing a lot. So if we look at the graphica for the enucleation time, the time we are spending to do the enucleation is like a linear with the prostate size, but the morcellation is not linear. It is, as you can see here, it is like a logarithmic line. So it takes, for me, the limitation of enucleation is the morcellation. So we can do enucleation of any size, but then when we have to do the morcellation, we can be in some trouble. So for me, that is something that is really important. If we look at this video, let me show this. We are trying to do the morcellation, and sometimes we have no good visibility, or having a good visibility, we can do a damage in the bladder wall, and then we can be in trouble. That damage is not very important, but we can do these holes, not this one that is not very big, but then you have to put the resector into the bladder, and then you have to fix it. If we sometimes we have these beach balls, you are trying to cut these beach balls because you cannot do the morcellation of them. And then when you are trying to do that, then you also are in trouble. And sometimes you are damaging the bladder, you don't see very well. And this is one of the most important reasons that, and the most important limitation for me of enucleation. Also, we are an academic institution, and also we have very specific patients with urethral stricture that has been treated, or patients with diverticulous. And also we are working with other techniques like aquablation. But let's focus in robotic adenomectomy. In the area of the minimal invasive surgical procedure, why are we doing this, and which are our results? The idea is to take out the adenoma, as we used to do in open surgery. With the robotic device, we have a great precision. It bleeds very, it bleeds less, and the recovery is really fast, and the patient is recovering his normal life really, really fast. When are we using this kind of procedure? In very big prostates, prostates that are bigger than 100 grams, 100 milliliters, and I think it has a role in this place. So it is not my idea. It was described in 2002 through a laparoscopic procedure by other group. Our friend Sotelo did the first robotic adenomectomy in 2008, And we are seeing that many groups are moving to this kind of procedures because they have no experience with the transurethral procedure and they feel more comfortable. When we are doing this surgery, we can do it transvesical or in this way. This way is my favorite. Is trying to preserve the urethral mucosa. So sometimes I do it transvesical, but if it is possible, I try to do it in this way. What I am doing is in the same way I do the radical prostatectomy. I will try to preserve the bladder neck. So I am opening between the limit of the bladder and the prostate, looking for the urethral mucosa. In this case, I am using the IUA-EAU RAS by Medtronic. We also have the Da Vinci device. In this case, is with the IUA-EAU, and what we are doing is looking for the plane and looking for the urethral mucosa to preserve it. You can find the plane very easily, and now as you can see here, we are trying to find very well the mucosa. Some groups has described to put green indioxanine through the urethra to see it better, but I think if you have experience in a radical prostatectomy, it is not very difficult to find the urethra. And then what we are doing is we are dissecting the adenoma in both ways, and we are trying to find the right plane between the capsule and the adenoma, and then we look for the urethral mucosa to preserve it, okay? So we are looking for the right plane. Once you have the right plane, it's really fast and really easy to dissect it, and you can be doing a very good hemostasia of the tissue. So we are dissecting the adenoma. You can see very well the plane between the adenoma and the capsula, and you can be doing a very good hemostasia. There you can see already the urethra in the apical part of the adenoma, and what we try is always to preserve this mucosa. Here you can see the bladder neck mucosa. We are dissecting one lobe. To be honest, when I do it transvesical, the surgery is more elegant than when we are preserving the mucosal urethra, because we are more afraid of damaging some of the tissue. So what we do is this. We are preserving the urethra. We are taking out both lobes, and you can even do it with a median lobe, but it is a little bit. You can see here, you have the urethra, you have the capsula, you have taken out both adenomas. I always try to do this, trying to look for the best option for the patient. So we take out all the tissue. Excuse me, this is not running. No. Hold on one second. Yes, we have here, and then we close the capsula. So we have the urethra completely preserved. We are closing the capsula. So we are putting a catheter, but you can release the catheter really soon. And many patients, they do not have hematuria. So it is a very less invasive procedure. It is a very fast procedure, and you can preserve the ejaculation. Then you close the capsula, and it is already done, the procedure. Okay, so we close with a barbed suture the capsula. You see that there is no bleeding. It is very easy procedure, and you feel very comfortable. All of us, we know very well the anatomy in this way, because all of us, we were trained to do the surgery with open surgery, so we feel very comfortable. I put this video because now we have a catheter in the urethra. If you look here, we are putting some liquid in the urethra, and you will see that the urethra is becoming bigger, but no liquid is coming out. That means that it is completely hermetic urethra and the bladder, so we have no leakage. So it is completely hermetic, the urinary system. So we feel very comfortable with this situation. Then what you have to do is to remove the adenoma. In this case, what we are doing is we are putting this device. We copied this from the gynecologist. They use this for treating back into the patient through a trocar. We put both adenomas into the back, and then what we do is to morcellate them in the back. So it is really safe because you are doing the morcellation into the back. You have no problem, and it is really fast. You just take it and you are pulling it, and then you are doing the morcellation, so you don't need to do an incision. Sometimes we do this. Sometimes what we do is to cut with the scissors of the device. So we are not spending so much money and so many devices to do the procedure, but it is really a good option from our point of view. And which are the results? Well, if we look at the results, Octavio Castillo published that the reduction of the symptoms, it's around 63–86% in the patients. The improvement in the quality of life evaluated with the IPSS, it is 70–87%. And improvement in the FluMax is 375%. If we compare with HOLEP, probably HOLEP is less invasive. I am not sure if the operating time is shorter than with robotics when you are training with robotics, and if the adenoma is very big, and if you are preserving the urethra, I am not sure if the hospitalization is also shorter than with robotic, but we will have a debate later. If we look at this table, is done by me, taking all the data that more or less it's in the guidelines and published. If we look at this table, we can see that with the enucleation techniques, we achieve the best efficacy of the treatment when we evaluate it with the FluMass, the IPSS, the quality of life, and the PSA reduction. And if we look at the hospitalization, the minor major complications and reintervention rates, we see that robotic simple prostatectomy is really very competitive, because if you are preserving the urethra, some of our patients can be discharged in 1 day. I will show you our experience and our data. So keep in mind that it is not so aggressive if you try to preserve the urethra. It is something very important for me, the sexual function. We published this systematic review in European of Urology just the last year, and evaluating 20,000 patients, 151 studies. The conclusion of our systematic review was that all the techniques that we are employing to treat the BPH surgery, they have an impact in the sexual function, not only in the ejaculatory function, but also in the erectile function. So I think it's something we have to take into account when we are working and we are speaking with our patients, looking for a good treatment for his BPH. So please keep this in mind. So we have a very good technique that is the Madigan technique, that is the urethral preservation technique for robotics for very big prostates. And if we look at our experience, it's a very small experience. We tried to do it in 15 patients. We were able to do it in 10 patients because sometimes you open the urethra, or the patient has a very big median lobe, and then when you are trying to take it out, you open the urethra, and sometimes it is really difficult to achieve what you want to do, but we were able to do in 10 or 15 patients. The median size was 119. It took us 95 minutes in the OR. The bleeding was 275 milliliters. 8 of 10 patients were without irrigation. We were putting no irrigation because it was completely closed, the urinary tract. The catheter was removed in 1 day in 5 of 10 patients, but we have to do in 2 patients recatheterizations. 2 of 10 patients were removed the catheter in 2 days, and 3 of 10 patients the catheter was removed in 5 days. The hospitalizations was in 5 patients 1 day, in 4 patients 2 days, in 1 patient 4 days, and the ejaculation was preserved in 8 of 10 patients. These results are very similar to a very small also data published by the Italian group of Giuseppe Simone and other colleagues in 2019. I know and I do understand that this is a very, very initial data and a very small sample, but I think it is not too bad results, and I think it is something to take into account. So if you ask me which are the pros, is that no matters the adenoma size when we are speaking of big adenomas, not for small adenomas. The functional results are really good. The complications are acceptable. We are not having bigger complications or more aggressive complications than with other technique. The learning curve is really short. If you have experience doing lab or doing robotics, it's a really, really simple surgery. It is not like doing other kind of surgeries. Probably we will have less strictures and less incontinence. I have no data to support this. This is my personal opinion. The cons is longer hospitalization. I am not sure about this. If you can preserve the urethra, longer catheter. If you preserve the urethra again, I am not sure about this. The blood loss, the cost is absolutely very expensive. This procedure, robotics is an expensive procedure, and it is more invasive. I am not sure if you are being fast and you are doing the morcellation and you are doing very small incisions. So in conclusion, for me, the robotic adenoidectomy is an efficient and minimal invasive option for treating BPH. It is a useful technique for large adenomas. I think we can do a very good postoperative control with few complications. If you preserve the urethra, you can remove the catheter really soon, even in 24 hours. You can discharge the patient in a very short period of time. And for me, it is a very good new option for very big, large prostates, because sometimes doing enucleation, the morcellation for me, it's a limitation of the technique. Thank you very much for your attention.
Thank you, Javier. So, any questions from the audience? Brief questions? So, Javier, I think we have a lot of questions, but we will leave it for debates, hot debates regarding robotic surgery. So, hope we will discuss all these things during these debates. So, dear colleagues, we are at the time. So now we have a short coffee break. Let's make it 7-10 minutes instead of 20, and return and to hot debates and continue. Thank you.
Thank you.
Thank you very much.
Wait now, no use riding. There's no need before go against the grain. With the rain, I've been here before. It ain't gonna work no. Been here before. It ain't gonna work no. Focus, your mind will be strong. No distractions, so calm. Wisdom all year long. And then take care.
קצר כנראה.
I've been here before. It ain't gonna work no more. I've been here before. It ain't gonna work no more. I've been here before. It ain't gonna work no more. Oh no 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 more. I've been here before. It ain't gonna work no more. No no more. I've been here before. It ain't gonna work no more. I've been here before. It ain't gonna try to hurt me with the word goodbye, though it took some time to survive you. I'm better on the other side. I'm all good already, so move on, it's scary. I'm not where you left me at all. So if you don't wanna see me dancing with somebody, oh no no. If you wanna believe that anything can stop me, babe, don't show up, don't come out, don't start caring about me now. Walk away, you know how. Don't start caring about me now. If you don't wanna see me dancing with somebody, oh. If you wanna believe that anything could stop me, don't show up. Lift my heart up when the rest of me is down. You entwine me even when you're not around. If there are boundaries, I will try to knock them down. I'm letting on, babe. Now I know what I have found. I feel we're close enough. I wanna lock in your love. I think we're close enough. Could I look in your love, baby? Now I got you in my space. I won't let go of you. Got you shackled in my embrace and latching onto you. Now I got you in my space. I won't let go of you. Got you shackled in my embrace and latching onto you. I'm so encaptured, got me grabbed in your touch. Feel so enamored, hold me tight within your clutch. How do you do it? You got me losing every breath. What did you give me to make my heart beat out my chest? I feel we're close enough. I wanna lock in your love. I to see you cry. Won't you please forgive me? I would have never tried to hurt you. I just needed someone to hold.
So, dear colleagues, let's continue our meeting. We need more time for coffee break, but time is of the essence. Today is Friday, so let's continue. Now we start, I think, the most interesting part. So we will try to find the truth. And how we can find the truth? Only in debates. And for debates, we invite the leading experts. So the first debate is regarding small and average BPH. So we will discuss, should we do enucleation or still do transureteral resection? Hot question, hot debates. So Mario Sofer from Enikeev and my good friend, and I learned a lot from Mario. So Mario, you are more than welcome. Please, the floor is yours.
Gratitude for the invitation and the opportunity to collaborate with this prestigious faculty. My task for today is to convince you that endoscopic enucleation of prostate is better than TURP also for small and average volume prostates. Let's start with definitions. According to AUA guidelines, prostates are classified by volume in 4 categories: small, less than 30 cc, average 30 to 80, large 80 to 150 cc, and very large above 150 cc. Based on the same document, doesn't work. I'm sorry.
Still, we are waiting. So, very quick question to the audience. Please raise your hands who perform enucleation for glands less than 80 cubic centimeters. Please raise your hands. Yes. Okay. Okay. A lot. So, and at the same time, please raise your hands.
Okay, I can continue?
Sure.
Okay, once we classify the prostates by volumes, excuse it, I did Dmitry, based on the same document, endoscopic enucleation of prostate is indicated for all volumes categories. It is independent of volume, either smaller or larger. And this fact is supported by countless studies. As such, my case is done. Thank you for your attention. Shabbat Shalom. This is a debate. Okay. HOLEP is more durable than TURP. In this US health insurance-based study, the reoperation rate for TURP was significantly higher than for HOLEP. And it happened in half of the cases in the first year after the operation. The postoperative use of alpha blockers and fibride after TURP was more prevalent than in HOLEP. I have to acknowledge that in the first 3 months, you can see on the right picture, the use of anti-overactive bladder medications was more frequent in the HOLEP group. But this study dealt with a very heterogenic prostatic volumes, not the specific volume that we refer in this debate. So let's see this very nice study, which was prospective, comparing the treatment of prostates smaller than 80 cc by comparison between monopolar transurethral enucleation of prostate and TURP. And this study showed that with the enucleation, more tissue is removed, the catheterization and hospitalization time is shorter, and we have more reduction in postoperative PSA. The complication rate and the profile of the complications were similar in this study. What happens when we go down to prostates smaller than 40 cc? In this case, that compared enucleation to TURP, it was shown that TURP causes significantly higher of postoperative bladder neck contraction. And this standalone also with the multivariate analysis. Beside the bladder neck diameter, the maximal transverse prostatic diameter, the intravesical prostatic protrusion, and UTI, TURP is an independent predictor of postoperative bladder neck contraction. What about this study comparing TURP to 2 procedures of enucleation, one the bipolar enucleation and the other the holmium laser enucleation? We can see here that the amount of tissue removed with enucleation is significantly higher with the enucleation procedures, but in the hands of this experienced group, even the operating time was shorter with the enucleation procedures. This study was designed to assess the risk of thrombotic events by either TURP or HOLEP. And it was done prospectively and randomized on prostate of 80 cc. These are the clinical results. We can see that the specimen weight was higher with HOLEP, as well as the catheterization and hospitalization. We cannot talk about the operative time. This result is not reliable since the operation was longer, but more tissue was removed with the HOLEP. But in terms of coagulability, with TURP, there is a higher level of prothrombin fragments 1 and 2 and thrombin-antithrombin complexes. Therefore, TURP may be associated with higher risk of thrombotic events. What about satisfaction? In general, patients are satisfied with our procedures for BPH. However, the regret is least in the group of HOLEPs, and the HOLEP had the best outcome. HOLEP and enucleation can be performed with miniaturized scopes. We can go down to 22 French and even 18.5 French. And today, we don't have instruments to perform TURP at this size, and even if we'll have them, probably they will be not effective. With this procedure, we can better maintain the body core temperature. We can have a reduction in the amount of irrigation, no need of meatal dilation, and this procedure reduces the early postoperative stress incontinence, thereby shortening the recovery period. In our experience, almost half of the procedures, of the HOLEP procedures, are performed on prostate with average volume, less than 80 cc. Only minority, only 3% of the cases are performed on cases of small prostates. In 20% of our procedure, we combine in the same session also other procedures needing lasers, like bladder stones and upper tract pathologies. So if we'll choose for this procedure TURP, then we'll need to have available also the laser platform to complete these surgeries. In this study coordinated by Dr. Lifshitz, not yours, but ours, Dr. Lifshitz, that assessed the trends in BPH surgery in 7 academic centers along in Israel along a period of 12 years, it was shown that TURP is stabilizing in a plateau with a decline, with a trend to decline, while the HOLEP presents an exponential increase. According to our prediction, the open surgery is going to cease in the following 2 years, and the HOLEP will have a steeper curve, closing the gap to TURP and becoming the most prevalent procedure for BPH within 4 years. In our department, the revolution was completed. We are 3 partners performing HOLEP already, and you can see the decline in the TURP and the increase in the HOLEP. We did not perform open surgeries anymore in the last 3 years. And on the right side, you can see the forecast. No more open operation, decline in the TURP, and only enucleation. In conclusion, endoscopic enucleation of prostates allow for more efficient removal of tissue, better outcome, less risk of bladder reconstruction. It can be used with miniaturized scopes. The catheterization and hospitalization period is shorter, less thrombotic risk, more satisfaction, and we can perform same sessions interventions. I forgot to mention also that this procedure, enucleation, can be done under antiplaquetar treatment. We can continue the treatment with mycopyrin or other antiplaquetar products. Under these circumstances, I think that we cannot perform EEP only in one situation, in the case that the surgeon is not able yet to provide this service. Thank you.
Thank you very much. I think maybe we can do debates now and afterwards questions to both speakers. Yes, so very serious debater, Dr. Shahar Aharoni. So I'm sure he also has what to say, what to answer. Shahar, please, we're all ears.
Thank you. Again, thank you, Dmitry, for this amazing event. And it's always an honor to stand after great speakers like Mario. And I want to give you my point of view as a functional urologist. So you've all seen the guidelines, but the Canadian and the US guidelines are quite clear about it. And still in those guidelines, TURP is the procedure of choice or gold standard, as English say. I draw the mic and end it. Let's talk about it a bit more. If we go to lower prostate than 30, there is no doubt. But this is not why we're debating, because if we want to ask, the real question is whether or not OLEP is the gold standard for average prostate. This is the question. This is what stands behind of this debate. For 3% of your patients, we are not debating. We are debating on this, on major patients. And as human beings, we always try to, we compare everything. We compare TURP to OLEP, we compare Messi to Ronaldo, we compare, we try to see what better, oranges or apples, and this is not the case. We are trying to find the gold standard, but what's it called, a gold standard? If you're an oncologist or if you're doing stones, it's very clear. You have a very clear and agreed endpoints, and you can all discuss the same. What are the endpoints in functional urology? What are the gold standards in BPH? And Asaf is still here. So Asaf Shviro presented this very nice opinion, how HOLEP is the new gold standard. And some things that they base their opinion on. Efficacy, low rate of adverse effect, objective and subjective improvements of functional outcome. And I have to remind you that the prostate is not what we're treating. We're treating the patient. We are treating symptoms. So what are the objective and subjective functional outcome? And I think that we're not on the same page. Because when people say we have objective functional outcome like QMAX and PVR, they are far from being functional outcomes. They are not functional outcomes. Functional outcomes are clear urodynamic studies done at the proper way. QMAX and PVR are very variable among patients, among the same patient, and you can't convince me that one measurement of QMAX shows any improvement. This is not what we intended to do, and this is what we learned from the MIST. From MIST surgery, we know that QMAX and PVR are part of the evaluation, but they are not, and I go back, they are not what patients are looking for. Patients want to see improvement in quality of life. This is why they came to you. They didn't come to you to reduce their PSA. They didn't come to you to improve their QMAX. If you want to improve their PSA and QMAX, do a radical prostatectomy. So I'm not interested in how much tissue you removed. I'm interested in how much you improve your patient quality of life. And when we're talking about functional outcome, show me the improvement of quality of life. And as you all know, IPSS is not the right tool for that. IPSS cannot measure quality of life after surgery. It wasn't intended to do that. We are using that because this is what we learned like 30 years ago, but this is not the clear tool. So we are trying to look for what is success, and Dr. Daraush and Gil Meyer will speak about success afterwards. But not right now, we are trying to assess success with the very old techniques that we are used to. So it's like searching for the car keys under the street light, which is completely out of date today. So if you look at this patient, you can say that there is clearly no gold standard. Every patient needs other operation, yes, but we know that gold standard or guidelines are not for all patients. They are what they call the endourology for the index patient. So let's take the index patient, a 50-year-old man with 40-gram prostate. Can we talk about an index patient? Of course not, because every patient is different. Every patient has a different phenotyping of the prostate. Some have median lobes, some have large prostate protruding the bladder, and some have only lateral lobes. Some differ on their lats. Some have bladder instability. Some have urinary incontinence. They are not the same. People are using different ways to empty their bladder. Some are using a dwelling catheter or CIC, and when we operate them, we have completely different aspects that we want to achieve. Sexual function. The only two procedures that have shown to preserve sexual function are UroLift and Resume. We can always try to improve our techniques doing OLEP, URP, medium low, but they are not intended to preserve sexual function. And I'm not talking about ejaculation, talking about orgasmic dysfunction, and Dr. Meyer will speak about it later on. And of course, we have patient preference. Not every patient needs the same thing. Some patients are very okay with the option that he will do a minor surgery that will give them quality of life for the next 3 years, and in 3 years they will need something else. They want relief for now, not for 10 years. So we have to discuss with our patient what do they look for the operation and what they require from us. So if you look at the options, and this is only part of the option that was mentioned today, and only few of the things that we can talk to the patient. This is not my idea. It's based on a lecture from the ICS. I just change it to my point of view, and you can use the street light and see. And you can see that every procedure has different advantages and disadvantages, and every patient needs to be we have to speak to our patient and understand what are they looking from the surgeon. So my point of view is that there is no prostate that I need to fix. And we need to change the way that we think. And if you know, this is Asaf, and this is a picture after his 100 aqua ablation case. Am I right? So Asaf clearly changed his mind. And instead of being a hammer, when everything looks like a nail, try to be a toolbox. Try to use many options and try to find what's suitable for your patient. Thank you.
Thank you. Any questions from the audience? Dear colleagues, please be active. Don't be afraid of some quick questions. So we have one question. Yes, sure, Mario. We have one question to you from our colleague from India. So join us online. So the question is, how can minimally invasive infiltration of the prostate, how can MILIP reduce post-operative stress incontinence?
It is because I think that the mechanism of damaging the sphincter is not the one that we are talking about right now. I think it is different. It is not about elongation of the sphincter, about longitudinal forces, but about the over dilation of the external sphincter. We are working on this research right now, and this is why you can find in the modern literature the fact that probably the apical release, the early apical release, does not influence the continence rate after this procedure. So as smaller the instrument, as less the chances to damage the sphincter. In addition, we should try to adapt the instrument to the organ and not the organ to the instrument. And this is the way how probably our patients after minimal HOLEP, minimized HOLEP, recover better. My question for Shahar is, after his great talk with many details about function, the subject of this debate was, if you have TURP or enucleation, what would you choose? What is the answer? Not if you have also aqua ablation, mist, and other procedures. You have only TURP or HOLEP or other methods of it.
This was the question, but this is not the question.
Good answer.
We live in 2024. Your patient has everything. Even if you offer in TURP or OLEP, you can go to the next door and they will offer him Resume or aqua ablation or UroLift, and patient will come to you and ask and tell you, what do you think about Resume? What do you think about urologist, what do you think about robotic prostatectomy? Would you advise me to do that? So in order to be able to speak to your patient, you have to understand what are the options and what is the best option for your patient, and it's not your decision to make. You have to give him the information, and your patient need to make this. You know, it's like trying to choose from a toolbox, and you can't use only one tool in order to do that.
Obviously, your point is well taken. Of course, we are speaking with the patients and we offer them everything and talk about with them about all the categories of the treatments that we have. So I don't think that you referred right now, again, I'm talking about, you didn't refer to the question of the debate, TURP or HOLEP. The next debate will be aqua ablation or resume. The next debate will be the other. If you have only two tools and the patient is interested only in TURP or HOLEP, the patient after the discussion is interested only in TURP or HOLEP. He has a dilemma. He has to decide. What would you prefer to recommend to this patient?
Okay, so
maybe we should, stop here and we'll invite a next speaker. And a moment before your talk, what do you think? TURP, HOLEP, laser.
Professor Herman, Thomas, please, can you please comment on the debates?
I would thank you very much for the question, because that is my beloved question. So the best treatment for a functional urologist to refer his patient to is enucleation, because the patient always gets the same. I told this to Paul Abrams, and I said, there is no TURP, unfortunately, Paul. There's just gradual tissue removal, and you cannot tell whomever you send your patient to what he gets. So the nice thing for a functional urologist, if he sends them to an enucleator, is that he exactly knows what he gets. And that is the big advantage, because the template is clear and the template is safer. So if we are talking about ablative surgery, surgical removal of tissue, then enucleation is definitely the best, because the patient always gets the same and not a variation or personal interpretation of the template. That's what I want to say. And of course, functional urologists have a different opinion. This is why I hired Matthias Oelke, whom you all know, now to our department to bring this to a different level. But my opinion is, especially for functional urologists, the topic of detrusor underactivity or acontractility is becoming more and more important nowadays. And for these patients, Tef Aho presented, and we will bring that up in our EAU Endourology prostate group. Enucleation seems to be the best treatment to relief of obstruction, even in those patients, so that they can void again. I agree. I do not agree with Marcus Drake that we cannot tell about it, because his data based on the upstream study was on TURP or variations of TURP. If he would have done it with EEP as the effective treatment, I think the data would have been a little bit different, especially with regard to life quality and successful treatment.
Great, thank you very much for this comment, and we'd like to invite you to continue right away to your presentation.
Javier just wanted to give a comment as well.
If it is possible, I would like just to a short comment. I do understand that the time is running. I would like to say that this is really very complex to answer. I think everything works. I think if you ask which one is the most effective treatment, for sure is enucleation. But I think there is something more. than this, because sometimes you do surgery to a patient, you get the patient destructed, and then he has incontinence, he has emergency, he has many things. So I think the problem is more complex than only to take out the tissue. And I think in the next future, we will be classifying patients and we have to work in that direction. Because here we were speaking about incontinence in the early apical dissection, in the size of the instruments. I do exactly the same surgery to all my patients, and some patients, they are suffering incontinence, the other not, because it depends not only the instruments, it doesn't depend only in the technique, it depends in other things like how is the detrusor, how is the sphincter, the age of the patient, the body mass index, and many things. So I think there is not a winner. I think there are many options, and I think we have to work in that direction, because we are doing the same for different patients, and we are having absolutely different results, different incontinence, different recovery, different emergency, different everything in many patients. So I think it's something we have to work in the next future. So that's it. I think there is not a winner.
Thanks, Javier. Thank you very much. So we are moving forward. Professor Thomas, please. So how to preserve ejaculation after BPH surgery? And the question is it really important for our patients to preserve ejaculation? And we hope to get the answer for this question also during this presentation. So Professor Herman, we are all yours. Please, the floor is yours.
Thank you very much for the kind words and kind introduction. This is a very important topic. I've been lecturing about this for the last at least 8 years. So first of all, I'd like to thank the Israeli Association of Urology and our hosts that we made it possible to do this once again. It's a great privilege for us to do it in these crazy times, to have this tool of Zoom that brings us together. This is the new ISUT and Urology board, but it's not the ISUT. The ISUT, the EAU and Urology is the different groups all together. And I'm very pleased and happy that you, Dmitry, and Mario joined our groups, the prostate group. We will put out a lot of nice papers in the future, and we'll do some good research that probably answer to a lot of questions that have been arisen today. And just a few comments. We have today the Day of All Saints, at least in my Catholic bubble. Yesterday there was the All Hallows Eve or Halloween, and just what we saw in the introduction, heard in the introduction about the horrible times that we face at the moment. I think there are a lot of terrible ghosts around that do a lot of damage to us, to our relatives, to our society, and to the spirit of the world. And I hope these ghosts will vanish. And I just want to say to you in Israel, in Tel Aviv, just stay strong and don't let yourself not get out of balance. All will come well. And I think we need to look for the good today and look into the future. And tomorrow is the day of mourning, the All Souls Day. I think we all have a lot of people to remember and to mourn about the souls that have passed. Just for that. Now to the topic, how to preserve ejaculation in BPO therapy. This is mist. This is the region where I am. This is the beautiful mist. And this has a lot to do with what we are talking about ejaculation, because we have actually a recontextualization. So we have the good God in one.
Thomas, sorry for interrupting you. Can we kindly ask you to be maybe a little bit closer to the microphone, because it's not so easy to hear.
Okay. Is it better now?
It seems better. Yes, it seems better. Thank you very much. Sorry for interrupting.
Okay. So this is the recontextualization we have today by the mist, because we have no longer inevitable results, but we have results that probably our patients also want and seek for. But we also see a productification. So if we talking about ejaculation sparing today, we think of mist, and probably that's the wrong focus. And this has a historical context. So there were inevitable rights in the past that have been in the age of enlightenment to liberty, equality, and fraternity. And if you wish so, this is Immanuel Kant of today and ejaculation. So the first one is Young with the TORP, and we have patients who claiming their right or freedom of ejaculation. And I think these studies really showed that there is a, let's say, an instrumental way to provide that, not knowing the template and not doing surgery. But we also have to acknowledge that this is a very presentism discussion today, because presentism doesn't understand the history, and that is why it's a little bit problematic, because we are coining techniques that are there as old and ineffective, which they are actually not. So we have heard about Madigan prostatectomy today, and of course you can do that with robots and laparoscopy today as well. So I'm a big fan of MIST, but MIST does not come as a meteor that hits us. So we need to be sensible in doing this. This is why I always like to stay above the mist, to have a greater view and a bigger picture on the whole topic. And my way of doing it is, again, the reason, and is anatomy and the template. I think if we consider this, we will have a bigger insight and see how we can serve not only a few, but all patients. So we know that Sigmund Freud has said it. Sex is the prime motivator and common denominator of all of us. I think Ruth Westheimer would fully agree. We don't have a lot of recommendations for that in the EAU guidelines, except that if patients seek ejaculation, they should get Urolift. We know that we have a different set of people today. We are not only having boomers, we have millennials and Generation Z, and they, of course, are prone to use technology, but the Generation Z is better. They try to understand and deliver. So this is why they are a better partner in the future, because they will treat us one day. So the boomers probably wanted to pee in a high bow or high arc, and the patients of today probably still want to ejaculate in a high arc. So that is a complete different endpoint. So talking about the patient with a catheter wants to void, the patient with the storage symptoms wants to lose his storage symptoms, and a patient with a high-grade obstruction does want to lose the obstruction. But this is a complete new endpoint. And only the aforementioned BPO guidelines of the DACH, Germany, Austria, and Switzerland, German-speaking countries have included that and said, what should we do if we have one or the other? And that's quite interesting. It comes down to the median lobe, what to do with technology, and surgery is independent of median lobe. And our functional urologist colleague was completely right. So what is bothering the patients is not the flow in general, it's irritation, it's storage dysfunction, and preservation of the bladder function in the end, what we need to seek for. But again, this does apply for a healthy patient and probably not for a patient who is a neurological disorder. I met Paul Abrams 2010, and this is still true in 2024. Pump and pipe, we need to have a look at that. And that is also, with the inclusion or exclusion for therapy, very important. And of course, this, as I said, is a huge problem. And if you have something like this, you don't start working up with minimal invasive therapy. So the question is, who wants to reach the climax or the ejaculation? Is it these two, or is it bricks? Yeah, who wants to reach ejaculation? If you look into the world on the right side, this is also true with regard to the budgets. So of course, first world can afford anything, but red and yellow are larger than blue. So if there is a need and if there's a concern, and if ejaculation is so important for somebody in Canada or Germany or Israel, then it should be an international need. So, but we see here, most of the people with low budgets will be the major population of this treatment. So if we advise something, we need to look how we can provide ejaculation sparing to the world. You wouldn't do aquablation in Zambia and not Urolift in Lagos because it's too expensive for all the people and they want to ejaculate as well, or maybe not. Maybe they just want to void and have the climax, not the ejaculation. So this is healthcare spending around the globe, and you can see your column there. It's quite a lot. And unfortunately, in these poor countries, people have to pay it out of their own expenses. So why should they pay for special treatment and we not? So this is probably not very social. And this is not only in low budget countries, but also in Switzerland. We have the same discussion here, and we will face another vote on a new legislation on that in November, late of November. What is the most expensive treatment is something which goes back to bad. So we cannot have this. And we have already said that even medication still is a failure of therapy, and that's the retreatment as second. So, however, this is a different treatment for a different setting. So BPO is a benign tumor which can potentially be cured by R0 resection, and that is enucleation, how to do it. And that other thing is something completely different. And if we treat BPO, we only need this. This is what we can do around the world without any additional technology. And that is what we have to keep in mind if we are talking about this problem. Do the patients have to choose between ejaculation and micturition? We will probably find out. What should we do if we want to preserve ejaculation? We should do this. Visual laser ablation of the prostate, contact laser ablation prostate. Nobody does it anymore. The data was fantastic. They're all gone. Nobody does them anymore. So this we have to keep in mind if we are talking about new technological solutions for ejaculation sparing that seem so promising today. I fully agree with what we've heard. They are very good, but probably they will rank as VLAB or CLV in the future because they don't stand the test of time. The nice thing about anatomy is, in this case, that everything that is good for ejaculation sparing is also good for early continence sparing. And the good thing about anatomy is that it's incorruptible and cannot be changed. And this is not a theory. It is true. So there's no cynics about focusing on anatomy. So we've heard this. This is the internal sphincter, longitudinal fibers and circular fibers. The longitudinal fibers do not go through until the bladder neck. You will see it just now. They end in the mid of the urethra. So we don't cut the longitudinal fibers. We preserve the circular fiber. The turquoise is the internal sphincter below. And the purple is the sphincter urethra, musculus sphincter vesicae at the bladder neck. In between, there's no longitudinal fibers. So if we preserve these structures and if we preserve musculus ejaculatorius dorsally, we should have a chance of preserving. And if you look into the templates of aquablation and what people doing Rezum and whatever have in mind is they stay away from the colliculus. And this is the reason why. This is the magic musculus ejaculatorius, which is pulling the verumontanum towards the bulbar urethra and is injecting the semen into the bulbar urethra, which then is pumped out by the bulbus spongiosus. If we do this technique in enucleation in 1, 2, or 3 lobe, doesn't matter. Just for you to understand, urethral sparing can be done in this omega technique, or as I presented as ventral and dorsal mucosa sparing in 2019. It doesn't matter. It looks like this. This is urethral sparing. If you do it a little bit more aggressively than we have seen this morning by Gomez Sancha, I'll do it up there. This will go into the press probably in January. And you can do on the right thing this ventral mucosa sparing, which also helps to preserve the musculus dilatator urethra, which runs here. So The more you do, the better you preserve it. And you have to understand that any one of us who is modulating anatomical enucleation of the prostate is doing it because of his own experience in the past. The data on ejaculation sparing in enucleation is poor if you don't look for the musculus ejaculatorius. You can come up to 50-50 if you stay a little bit away from the veru. I said we need to stay on the lobe, so to preserve more mucosa and submucosa around, which you can see nicely here on the right side. And this was tested a few years later after I presented it at TNT, which will be end of November. Cesare Scofone asked me to have a look at that. You can register online. It's free access online at TNT in Torino, end of November. Just go to TNT and the urology. And he checked it and he found out exactly it's about 70% what you can reach if you stay away from the follicle with enucleation complete template. If you modify that template and leave dorsal tissue behind of the transitional zone, something which we haven't seen today, because we saw only anatomical enucleations today, then you stay even higher, like you do if you do a E-TERP. But this translates, of course, into a higher residual transitional zone and therefore regrowth. So that is not anatomical. This is a modification. What I provide for patients, again, I showed at the same meeting 2016, was median lobe enucleation. Even if you don't see an endophytic median lobe, this translates into an antegrade ejaculation of 87%, 90%. This is almost on the level of reason, not on the level of urolift. So you can do a lot with conventional. You don't need to even have a laser. You can do it with a sling. And look at that. The quality of life comes down to 1.2 if you do median lobe enucleation. This is amazing. If you look into median lobe resection of our friend from Stephen Kaplan from New York, you don't end up with 1.2, you end up with 2.3. So there's a difference if you resect the median lobe or if you enucleate the median lobe. So if you resect, you end up with a little higher antegrade ejaculation rate, but still the patient probably wants also to have a good quality of life for voiding. So this is why I advocate median lobe enucleation, especially in those patients who are not suitable for minimal invasive surgery. We've seen that of Javier. It works well as well, probably not as high. You go to 80 or 85%. This is a constant of Madigan robotic adenomectomy. So when I always think about MIST, these are fantastic technological solutions for patients, for colleagues who are not deep dived into anatomy, but you really need to look into the inclusion and exclusion criteria. I think they are paramount to provide success, not only for ejaculation, but also for relief. Again, this slide I showed, you have to counsel your patient that probably they will have to continue with medication, and it's not all gold. It has side effects. And that is also true for retrograde ejaculation and erectile dysfunction as well for PUL, as well as for RESUM in larger cohort studies. It's also true for prostatic embolization. This was a study in the UK, and look at that. It's not an ejaculation preserving at all if it's not done in high specialized center, and even that you have a higher treatment rate as well. So this is because we have to acknowledge that a different template translates into different results. Look here, water 1, retrograde ejaculation very low, but a very small template with a 20% PSA reduction. And with a larger template, it was a higher rate of retrograde ejaculation. So what Kevin taught us, if you really want to preserve the ejaculation, you have to stay more away from the, like the water one template to achieve a high antegrade ejaculation rate. It's all about anatomy. And we have to ask ourselves whether this can be our primary focus, especially in healthcare system, which is provided by solidary funds. I think we need to understand whether we want to cure BPO or if we want to manage BPO. If we want to manage BPO, I think we can will in ejaculation sparing based on solidary funds. But if we want to cure BPO and have in mind that this money comes from our social funds, I think we need to put this to the patients' funds, because I think the cheapest thing is the cure of BPO, not the management of BPO. And we have to be sincere that these technologies all have a different leverage, and this translates from the volume or the percentage of volume reduction. But we need to acknowledge the patient wants it, the patient prefers it, but we need to not manage the patient preferences, but we have to discuss with the patient whether the expectations in both fields can be met or not. So therefore, I would conclude and would say it's about anatomy, not about tools and the template and the resources, how we preserve antegrade ejaculation, and to what extent and to what liability we can preserve antegrade ejaculation. And as always, focus on anatomy. And if we focus on anatomy and use standard tools, we can provide this important topic to almost all of our patients. But what I believe in my expertise is if you counsel your patient, the patient is afraid of not having an orgasm and not reaching the climax. And if this is gone and from the table of the patient is no longer or significantly less interested in antegrade ejaculation. Thank you very much.
Thank you very much. Any questions from the audience? No. So I have a short question. How do you treat anejaculation or dry ejaculation following surgery? Pelvic floor exercises, tricyclic medications. Do you perform urine tests following ejaculation? How you treat it?
So first of all, my patients, I have a lot of time, counseling time with my patients. The normal patient who is informed, and I inform my patients, it's about, even if you see 70 or 60, if I do an enucleation, I say it's 50-50. The patient anyway will see a decline of volume, not only because of the surgery, but also because of the loss of tissue. And most of the patients don't have an anorgasmy. They have a retrograde orgasm, retrograde ejaculation. And it is not bothering when it has been discussed before. It is a worrisome condition if it hasn't been discussed before and the patient and the partner gets afraid. That is what I can tell. I'm not doing any, I don't believe that pelvic floor exercise reverses retrograde ejaculation. It could potentially have a benefit, but it is not in my practice. It's not in my practice, and it's not what patients seek in my place.
Okay. Another question, please. If you do a bipolar enucleation or a HOLEP, do you think that you need to adjust energy levels around the apex or during this the early apical dissection? Would this have any influence on ejaculation?
No. The answer is no. Because,
thank you. Good answer.
Because it's about, I think it's, I always say, doing the right things for the wrong causes. You know, if you think that you do yourself, your patient, an advantage if you lower the energy, for example, of TFL or holmium yak, you do worse, because then you have more coagulation and less ablation and vaporization. So going below a threshold can worsen the situation. This is why I say I go straight 60 watts, all the prostate, except if I want to coagulate, punctual coagulation. And that is also true for bipolar. I use bipolar with the lowest coagulation setting, knowing that this will have deep tissue effect. And this is the same thing for the contemporary laser probes we use today, Holmium, TFL, and Tulimiac.
Thomas, very, very brief last question. Let's pay attention to our colleagues who join us online from all over the world. So the question is, which section of mucosa of urethra is important for ejaculation, dorsal or ventral? Can we answer?
It's around, so all techniques today preserve the ejaculatory plate, which is a coin. It is not there. I think if we preserve the distal urethra, this is why I always speak from distal urethra or urethra sparing. It's true. I think you should not only focus around the veru, but if you look into the grooves, you see all the expiratory openings. You have to preserve them as well. This is where the volume comes from. The volume doesn't come from the other parts. So if you preserve that, this is why I do a horizontal incision and no longer an omega incision. You saw me doing a horizontal incision because then if my head is now the veru, all the ejaculatory ducts are here. So you can preserve that. But in the end, the ejaculation after that is disappointing whatsoever because the volume will be lower, the force will be lower, and that is it. And there are enough papers around who tell that almost 85% of all patients who are afraid of ejaculation disorder already have ejaculation disorder. So we are no sorcerers of ejaculation. We are probably good craftsmen in relieving obstruction.
Thank you, Thomas. Thank you very much. And once again, a very, very interesting talk. And we looking forward also to see you here in Israel in the nearest future. Thank you very much. So, dear colleagues, ladies and gentlemen, the hottest debates. Javier?
Only one comment. Congratulations, Dr. Herman, for your wonderful presentation. It was amazing. I like it very much. Only one comment. We do have a couple of studies published in Journal of Sexual Medicine developed by Hermann Post from Germany and from François Giuliano from France, telling us that 10 years ago that we were not doing so much, and I think were not included patients doing whole lab, but saying that the majority of the patients are not suffering retrograde ejaculation, but an ejaculation. So I think this must be considered when we are speaking about recovering the ejaculation, because the majority of the patients, they are not suffering retrograde ejaculation. They are suffering an ejaculation. That is the only thing I wanted to.
Thank you, Javier. So now you will also join these debates. So it's very interesting. What we will know about glands more than 300 cubic centimeters. So, and the first is Dr. Ehud Nessen. So please, looking forward.
So thank you, Dr. Enikeev, for this wonderful meeting, and Dr. Herman for inviting me to speak about those extremely large prostates. I think it's a good opportunity also to, as treasurer of the association, to thank the supporting company, Eldan and Dover and Technica for allowing us to do this this wonderful day. So this is also a great opportunity for networking and connecting with other people. This is, I hope you can see it. Saw it in Elon Musk Twitter, and I liked it. So hello, my name is Nessen. I'm an endourologist specializing in HOLEP procedure. I've been doing HOLEP since 2009, now 15 years. And when I started doing this procedure, there were probably 20, 25 surgeons in the North America that were able to do this, and a couple of dozens in Europe. And now it's great to see how this thing has developed and progressed. Let's see what we're looking at when we're looking at those extremely large prostates. So this is my personal data for the last 4.5 years. you can see that actually the 200 plus or 300 plus prostate, these are not a lot of prostates. This is like 5%, 6%, more than 200. Most of the prostate are what we call normal size. From all these procedures, I had to open a patient only once. And it was not a huge process, only 250-gram prostate. And it's just a weird anatomy. So truly, HOLEP is good for any size prostate. I think we're gonna go ahead and see more large prostate. This is a population study from Norway. You can see that over the expected several decades, we can see much older guys, and older guys tend to have larger prostates. So probably going to see extremely large prostate more and more. We already discussed the guidelines today, and you know, for the EAU guidelines, HOLEP is size independent, or is the procedure of choice for extremely large prostate, but the robotic simple prostatectomy is not incorporated, probably because there's no good, or there's not enough data on the AUA guidelines. It is part of the recommendation. This is actually the only randomized controlled trial comparing HOLEP and HOLEP, laparoscopic simple prostatectomy, and robotic simple prostatectomy for a prostate larger than 120 grams. There was, as expected, the functional outcomes were virtually the same between these procedures. There was longer operating time for laparoscopic simple prostatectomy and higher blood loss for the robotic or laparoscopic simple prostatectomy. There was longer hospital stay. Same catheter time, and in this study, the catheter time for HOLEP was about 4 days. That's, I would say, more than we usually see nowadays. Same stress incontinence post-operatively. It was resolved in the robotic group, but only partly resolved in HOLEP. There was a little more long-term stress incontinence. Interestingly, there was the same urethral friction rate in all groups, 2 in each group, and there was mentioned that there was a little more storage symptoms in the robotic arm. If we're looking at the time of surgery, this is a symptomatic view of HOLEP. For extremely large prostate, you see the sizes, it's 200 prostate, and you can see that generally, I would say on average, the enucleation time is about 1 hour and 15 minutes, and morcellation time is not that bad actually. It's 45 minutes, and you know, when you do those extremely large prostate, it can take up to an hour even for morcellation. I think the problem was more with the old morcellator. Now with the modern morcellators, the morcellation time is not that bad. You just need to be patient. And if you add another 30 minutes of hemostasis and setup for 20-30 minutes, you end up with 2 hours and a half for extremely large prostate. I think it's more than reasonable, and I don't think it's a real problem for me, at least. One thing that's interesting is that this is a case study of a HOLEP for extremely large prostate. You can see what I mentioned there is that there's on the prostate that are really big, above 200 cc, there's a transient stress incontinence, or the rate of transient stress incontinence is slightly higher. You see it's 33% for more than 200 cc, and it's less for smaller prostate. It goes away. And I think maybe it's because of the tethering or the pulling of the scope around the apex for those extremely large prostate. And I do see a little bit of transient or more transient stress incontinence for those extremely large prostate. I'm not sure if it's because of that tethering or pulling, or just because the apical tissue is actually protruding into the area of the sphincter. But anyway, it goes away. It just takes time, and you need to consult the patient about it. How do you know if you can able to do the a really large prostate? Actually, the only thing you need to reach is the bladder neck.